Robert Francis is not here yet. He was due here at 9, but he's on his way, so he won't be long, and same with Camilla. We've got apologies from Lewis Appleby, who's away. Is everyone happy with the minutes? I mean, they are far too long. I've already told Claire that. We're going to cut them down by at least half for the next meeting, but we thought they should be full given the content of the last meeting. But is everyone who's at that meeting happy with them? Thank you. I think all the matters arising are covered by the agenda. If they're not, I'll pick anything up at the end. Now, we were going to start with the update on the Mid Staffordshire Inquiry with Robert Francis. As he's not here, we're going to skip over that one and come back to it and ask David to start on the Morecambe Bay review, please.
Okay. Thank you, David. Good morning, everybody. So the Grant Thornton report contained a number of comments, observations and recommendations in relation to CQC's practices and procedures. And what this report is an attempt to do is set out a response to those. As you know, we published this report on the 19th of June. David and myself appeared before the Health Select Committee hearing on the 3rd of July, where the focus really was on the history of the decision making around the publication of the report and the issues contained therein. We've also had contact with both Cumbria and the Metropolitan Police, and there's also the intention from the Department of Health to have a further independent inquiry into Morecambe Bay. So what this report is doing is attempting to summarise where we're up to against all of those objectives. So if I go through briefly, David, without presenting each item, section 3 of the report is really responding to the comments contained in the Grant Thornton report about the policies, procedures and practices within CQC and how we take those forward. So we cover initially the approach to inspection. The majority of the issues raised are picked up through the strategy, and there's a further report from Mike later on in the agenda which sets out in more detail how we intend to move forward inspecting hospitals. So I'll not cover that in any detail and leave that to Mike. We further cover the approach to risk assessment in the way that we make our judgments about services, and again the strategy picks up the importance of surveillance, and indeed the 18 hospitals that Mike will inspect through the latter part of this year have all been selected using that surveillance methodology, so it's now beginning to be applied and is a much more transparent approach to risk assessment. The duty of candour is currently being discussed with the Department of Health in terms of the regulatory changes, but the issue from Grant Thornton was really about the Fielding report and whether CQC knew about that report and at what stage it knew about it. CQC does now oblige providers to disclose critical information following registration, and that's one of the changes, and we'll make further changes there. The Care Bill currently before Parliament, just gone through the committee stages, does introduce a failure regime which will have a clearer roadmap for how failing organisations need to be dealt with, and also Grant Thornton repeats many of the recommendations that the Deloitte report made about how we can improve the way that we carry out investigations. Recommendations about corporate governance, and the first meeting of the Independent Governance Committee met yesterday, and recommendations about operational governance, which again will be picked up later in the year, and we do intend to publish the full list of trusts in September of this year. We will pick up the recommendations about training and guidance, and an important piece of work moving forward is the development of the academy, which is to support the development of our staff and their training, and I think that's picked up later at Chair in the seminar this afternoon for board members. I've covered the changes to registration. We will set performance targets much more clearly to reflect our changed activity, and that work is going on. And again, one of the critical issues in Grant Thornton was how we worked with other organisations, other regulators, Parliamentary and Health Service Ombudsman, and a lot of work is being taken forward in that respect. So that's the work we're picking up through Grant Thornton. There is an annex which goes in more detail to the specific paragraphs in the Grant Thornton report that I hope reads back to the paragraphs in the covering report and demonstrates the connection between our current work programmes and the Grant Thornton recommendations. Additionally, we gave commitments to the Select Committee, and as is usual in these cases, we followed that up in writing to the Select Committee, and that letter is attached as an appendix to this report. We also gave commitments to follow up against current and former members of staff to consider whether there are any employment issues that need to be pursued. We've retained Hempsons to advise us on this, and that work is current in terms of current members of staff. Literally that work is going on in real time now. In terms of referrals to the police, there are two dimensions to this. The firstly was the dimension of any criminal investigations that Cumbria Constabulary were undertaking, and a copy of the Grant Thornton report was forwarded to Cumbria Constabulary following the last meeting where that report was considered. They've written back saying they don't think there's any grounds for any further consideration of that report in that respect. There was a second issue which followed an MP making a referral to the Metropolitan Police about misfeasance in public office. We learned yesterday that the Metropolitan Police have now referred that to Cumbria Constabulary, and they'll have to consider that in their own time. And then the final matter, penultimate matter covered in the report is the announcement by the Department of Health that there will be a further inquiry into Morecambe Bay, and Dr. Bill Kirkup has been retained by the Department of Health to lead that inquiry. My understanding is that Dr. Kirkup has been meeting with the families at Morecambe Bay, and following that meeting he'll finalise his terms of reference for how that should move forward. And then the last issue I draw attention to is the fact that James Titcombe, who was one of the complainants in the covered in the Grant Thornton report, continues to voice his concerns as to whether the conclusion of the Grant Thornton report meets his original concerns. Subsequent to James raising those concerns, he's received a letter from the chair of the Health Select Committee, Stephen Dorrell, and I understand that James is accepting of the explanation that Stephen Dorrell has offered him in relation to the relationship between the work that we did and the commitments that we gave to the Parliamentary Ombudsman and the appropriateness of that, effectively repeating what we said at the Select Committee, namely that we should make independent decisions and they should be not contingent on what any other organisation or individual determines. We considered this at the Governance Committee yesterday, and I've been asked to write directly to James Titcombe, setting out the importance of our independent decision making and that not being contingent on any other organisation. So I'll do that in the next 24 hours. So I think what I'm asking, Chair, is for the board to note and comment on the activities that we've set out. I hope that's a full, well, not explanation, but it contains an explanation of a full set of actions which are being taken forward to respond to the changes. Thanks, Chair.
Thanks. Robert, do you mind if we just finish off this item and then come back to you in a minute? We won't be long, I think. Kay.
Okay, thank you for the report. There's two things. One is whether, I think it would be quite helpful if the Davids could sort of report back on the meeting that you had with the families at Morecambe Bay, to report to the board and the public on sort of how that went and what you got from it. I've had some positive feedback about it from the families, but I think it would be quite helpful for the rest of us to hear how it went. And the other issue is, it's actually not a central issue in the Grant Thornton report, but I think it is a central issue in relation to the what happened at Morecambe Bay and elsewhere, and that's around this issue around investigations. Because what I hear at Morecambe Bay and from other family members, and this was yesterday hearing another two, is that there's really not clarity about what happens when things go very badly wrong. You know, when someone is an unexpected, this is in healthcare, whether there's an unexpected death or, you know, a serious untoward incident. And, you know, we've got the Ombudsman, we've got our investigation powers, we've got the coroner. You know, and just thinking of Morecambe Bay with James Titcombe, initially the coroner was not going to look at that, and he pushed, and it ended up with a Rule 43 letter. So it's very sort of hit and miss. I mean, I don't know exactly what the answer is, but we have also, you know, we've got our investigation powers. There was a lot of criticism about disbanding the central investigation team, and we might want to not necessarily think, oh, well, we'll recreate that, but to actually think a bit more about, because we had the Deloitte review, which essentially said that how we'd been doing investigations wasn't really helpful, shall we say. But what I'm not sure is how that's going to, you know, how our investigation function is going to pan out as we go along, and, you know, whether there is going to be sort of central type investigations, or whether it is going to be absorbed locally. And if it is absorbed locally, then we need to make sure we've got the skills there. But there's also this wider issue about investigating, you know, in general, you know, because there doesn't seem to be guidance or standards as to what should happen, and families are left sometimes not able to bury their family members, to be honest, and they don't think lessons are learnt. They feel that trusts cover up, you know, and it's all a bit vague. And I just wondered if, as well as considering our investigation role, whether it was worth taking a lead in trying to sort of thresh that out more generally, because it isn't just about us.
Thanks very much, Kate. Maybe on the second part, we might come back to you, Mike, on that, to sort of think about what might trigger an investigation from our point of view. But on the first, on the meeting with the family, do you want to just do that, David?
Okay, so following one of our conversations with James Titcombe, David gave an undertaking to go up and meet the group of families that are being convened by James and other colleagues, other families in Morecambe Bay, who all have an experience of maternity services in Morecambe Bay, which has left them with complaints to make and grievances to air and a dissatisfaction generally. And so we went up last Thursday to meet 5 families who had all in common had lost their children at Morecambe Bay. And over about 2.5 hours, they told us their stories of their experiences, and each one told their own story. It was powerful and humbling, because these were, if I use this, and I don't mean this in a dismissive way, but ordinary people who were not part of any organised groups or anything else, who just told their stories in their own language. The common issues which came out, I'm sure Robert will echo this when he speaks, were they didn't feel listened to, they didn't feel believed, they felt fobbed off. They said they were dealt with by people who felt they'd got an aura of invincibility, I think was one of the quotes that they used. They felt they'd been spoken to dismissively and without compassion. As they all told their stories, what emerged was what they'd got in common. They'd all been in hospital on a Saturday. There were complications with a birth that they were all asking for caesarean sections because of the complications with the birth, and they felt they weren't being listened to in that request, and their requests were being dismissed. Following the deaths of their children, they felt it was difficult to be listened to again. A number of the people where liability had been admitted felt that they'd not had an apology for what had happened, and felt that they'd not been listened to or treated in an appropriate way. In fact, they'd come together as a group largely by understanding each other's stories through local media publishing their stories. So in a sense, the press acted as a means of sharing stories and them gathering together, which has resulted in this action group being taken. We understand there's about 50 families that are in this position. All are consulting legal advisors in relation to this, 2 different firms. One has about 30, one has about 20. So we saw a smaller proportion of the total number of families, but the stories were powerful and humbling, and I think we both came away struck by the power of those stories, but also the importance, I think, for us of actually understanding the voice of people who have a complaint to make, how we pick that up in our inspections moving forward, how we assemble some of the data that we need to explore just how people's experiences of services are captured at a local level and how improvements take place. It flagged up issues around engagement with people, it flagged up the issues around governance, and some of the challenges that exist for liability and apologies to be issued, about how open organisations can be if they know that they've actually not got something as right as they need it to be, or where they've just got it plain wrong, quite frankly. I think, speaking to your second point, Kay, I'll let Mike come in on it, but I think it also speaks to when do you detect a pattern from individual complaints? When does one story become a trend, and how do we assemble that? And one was struck with some of these deaths began to occur in 2006-07, if I've got the chronology, and went on over a period of time. So each was an individual story, powerful in its own right. Together, the 5 stories made quite an impact. Even more than 5 stories would make a bigger impact. So how do you get at those stories? Is high caesarean sections a good sign or a bad sign in a hospital? So there's some judgments to be made about how we assemble those stories, but nonetheless powerful and humbling stories. I don't know whether you want to add anything.
I'd add one thing, that I mean, one of the women there, called Margaret, lost her baby on Christmas Day 2010, and now we had inspected that maternity unit in June 2010. You know, if we'd found something then, you know, that baby might have lived. I mean, so it brought it home to me, you know, just how important it is, our inspections. You know, that was pretty grim, actually. But okay.
Just on the point of the wider inspection thing, do you think there's a possibility of us taking some kind of leadership role, or trying, you know, because there's our inspection role, but there's also the wider, you know, it takes in the sort of coroner's office and the ombudsman. I mean, it's all very sort of vague and hit or miss, and it doesn't seem right that an unexpected death or a serious untoward incident is not, you know, there are not standards for investigating that.
I don't have an immediate answer for you, Kay, except to say that with our new hospital inspection programme, there will be 3 triggers. We will be doing our comprehensive inspections, we will be doing follow-ups from those comprehensive inspections, but we will still continue to do responsive inspections. And what I think we need to do some work on is what will the triggers be for a responsive inspection. You know, how many never events? Is it a single never event, for example, or is it more than that? What are the clusters of things going on? And one piece of work that we set in training just yesterday was looking at what had triggered investigations in one region over the last few months. So, because I need to get an impression of that to see if we can come up with some general principles from that about what should be done. So I think that's something that definitely in our sights, but we haven't yet got an answer.
So mine was just a very basic question about, there's something here about, in the grid, about board agendas and minutes, failure to discuss UHMB in the past. It's a more general question about the worry list, and not just when something is spotted, but the follow-up to worry. To what extent is that featuring in the we're new board members, but is there something that we can do more robustly to bring that stuff surfacing at every meeting or at an appropriate frequency. Special investigations may be a way of getting it onto the agenda. There's a constant agenda item. It's not just the Morecambe Bays, it's actually the worry list where there's some lower level follow-up but actually should escalate, and the extent to which the board should be cited on that.
I think it's an important point, Jennifer, and so I do an email out to board members every Friday where I try and get in the topical issues that are coming through, so there's a kind of board members are advised in real time. We've said that we'll publish the list of inspections based on our surveillance methodology in September of this year, and I think one of the references in the report about governance and the need to get that operational governance stronger is to ensure that there is that line of sight between the board and those issues that we are concerned about. I think on investigations, just to connect the investigations, the Deloitte report said this is a strategic tool which is not being used strategically. It's being used as part of a tariff. So when all else fails, investigate. And the recommendation from Deloitte, which I think, well, we have accepted, is that we will use these strategically and not part of a tariff. So I think Mike's point about responsive inspections is really the tool that we've got where we continue to have concerns about SUIs, never events, or where we think there's an emergent pattern, and it's a surveillance approach that will give us the intelligence whether there's a pattern, which will then trigger whether there needs to be a responsive inspection. And our commitment is that we'll, in a sense, have monthly meetings on the surveillance to see what changes are taking place within a month about whether any immediate action needs to take. So our month-end account will not be a financial account, but what does the surveillance information tell us about whether there are any triggers in that intelligence, whether we need to take further activity.
That would come to the board and there would be named sites that would be, yeah, thank you.
Just elaborate on that slightly, please.
So we have a paper later that looks a bit about how surveillance will roll out across the different sectors, because this is true for mental health and learning disabilities as it is for acute health, for example. We will expose on a monthly basis where what our surveillance is telling us. I think the piece we need to get right is not to just be saying, and it's the same 10 hospitals we're, on average most worried about, but also to flag up where something has substantially changed, whether that's a mortality alert, and that's probably the area of our surveillance that's most developed so far. But I think we need to be clear, both operationally and to the board, where something as substantial has changed that would therefore trigger something different to what you might have otherwise expected.
Anna.
Sorry, this is a really geeky point, but I mean, I'm really conscious that in relation to what Jennifer was saying, that the I mean, we've had lots of conversations in the board before current members arrived, and it's really important that we have this conversation now. But we have the Audit and Risk Committee, which plays a role in looking at risk. We've got the new Governance Committee, which plays a role in relation to at least whistleblowing and possibly some other elements. We've got the weekly reports that David does, and I just think there's a little bit of narrative we need to have around that, about how things go from A to B and how they then surface as a collective set at the board at appropriate intervals.
I'm sort of asking Michael, on your right, Michael Meyer, that is, to sort of think through this whole governance structure, the relationship between the Audit and Risk Committee, the new Governance Committee and the board, so we're absolutely clear, where responsibility lies. And I think we're planning to bring a paper back to the board at the end of in the September meeting, Anna. Okay. Steve?
It would certainly help me if we could have something come to the board that puts the investigations into context of the new inspection regime. We saw the Deloitte's report, and David said we accepted all the recommendations, but I'm not quite sure where this is under the Section 48 powers, I understand, the investigations, where we're now placing that in the context of the whole new range of inspections. And it would certainly help me if we could have that discussion, because it is a very different power, and I think we held it in reserve rather than used it since the Deloitte report, and I think the Deloitte report criticised us for making it just another type of inspection. It wasn't much more than that. And I think we need, it would help me to have that discussion here about how that fits into the spectrum of the powers that we exercise.
Maybe, Mike, at the next, in September, we can address that issue. Okay, thank you. Paul?
Two linked things. It seems to me that the NHS for some time has been trying to have an agreed definition of what a severe untoward incident is. And back to your point, the public and we need that to be settled. And at the moment, it's very different in different trusts. I think it wouldn't be beyond monitoring the TDA and ourselves to say this is an SUI, and therefore we know how many SUIs are in different places. Because it really, within a trust, it can vary as they change the definition quite a lot. And so I think we need that basic information. And I think the second thing that links to that, and that this Kay raised, and I think this might be something for Healthwatch to pick up, is after ANCRID reports on complaints, there's going to be quite a range of different things that the public can do. That involves coroners, does occasionally involve the police, does involve a complaints procedure, might involve us, might involve the Ombudsman. And there needs to be some sort of route map to get through this. What do you do, when do you do it? Because it is just, as you were listening to those stories, you could pick an accountability out of the air and try and get some, and then there's CCGs and there's trust, so all of that needs to be, so I'm not saying, and I think it probably would be quite useful for Healthwatch to say we will explain this to the public and to the NHS and to us.
Anna, do you want to?
Well, just to say that we've started, and I think it's a good suggestion that we should finish. So we've put a schematic on the website, which actually local Healthwatch are adjusting and developing for their local environment with names and contact details. And the schematic at the moment is about how to complain in the first instance, which is frankly quite complicated enough as it is, and needs considerable change in order to make it accessible. But this is an attempt at least to explain to people where they need to go for which bits. So we're rolling that out with local Healthwatch to try to ensure that if people can't find their way through the system, that they are helped. And I think this is like this notion of kind of how do I get something then further investigated beyond complaint is an interesting addition. So I'd certainly take that away, Paul.
Yeah, I was very struck by, I think it was Lisa, one of the ladies at Morecambe Bay, just saying that she was confronted by this aura of invincibility, which I can totally understand, actually. How do you start to take on the NHS?
Can I just say, in respect of that, I think one of the things that's certainly emerging from our complaints work very, very strongly is the sense that of two things. One is the need for enhanced and more accessible advocacy on behalf of consumers and users of service in a situation where they have complaints and issue or concerns and feedback that they want to pursue, precisely because they feel vulnerable very often in those situations, and because the system is really rather complex. And what you see in for instance, some of the things that Kay is saying is someone taking on that role in a way which is accessible to some, but for which many thanks, but not accessible to everyone. So the kind of notion of advocates out in the system is really important, and I think the second element of that, then, if you're going to have a system which is more accessible in terms of help and support in that respect, is it's actually having a brand around it, so people know that's where they can go for help. So I think this is all part of making complaints and concerns actually work rather better.
Thanks, Anna. I think unless anyone wants to chip in again, I think that sort of leads us on probably to Robert's sort of maybe reflections on your report and at Mid Staffs, because there are some common themes coming out, I think on this discussion as well. So Robert, can I hold it over to you?
Well, thank you very much, David, and I'm sorry that the transport didn't get me here on time. Well, thank you very much for inviting me to come and talk to you. I'm sure we all now share a common experience, and it's that, and listening to David, it's clear to me that so, of the impact that listening to patients and their families in relation to their individual cases has, and certainly the impact it had on me to spend in my first inquiry, 3 continuous weeks listening to and talking to families at the rate of about 3 a day about their appalling experiences at Stafford Hospital, all of which are summarised along with many hundreds of other cases in the report, had a very profound impact on me. And it taught me this, that it is the reason we're all here, and the reason everyone is working in the health service is actually to serve patients and to help them with their health needs. And somehow or another, the system, vast as it is, complex as it is, necessarily so, has a tendency to forget that, which is an extraordinary fact, but it is true. And so I firmly believe that the principal lesson to come out of the stories that I heard and the account I was able to give about the system as a whole is that whatever else the system does and everyone in it, we have to stop and remember why the system is there, and we have to stop and listen to patients and their family. And allied to that, something, an echo which I've heard here just now, is that information coming from patients and their families should not be rejected as being irrelevant or not very helpful just because it's an individual case. I, as a result of what I've done, receive posts, as I'm sure everyone else here does, from individuals who have had usually rather bad experiences. And a fairly common theme, not universal, but a common theme, is that the reason they've written to me, and no doubt lots of other people, is no one has actually responded to their case. And without that, the harm that was originally done, whether usually unintentionally, of course, sometimes carelessly, but always unintentionally, at whatever hospital it was, is actually aggravated. And not only has someone been injured, or maybe in some cases has a patient died, but their family are then injured further by being ignored, or that's the way they feel. So the first lesson, I think, is we really do have to listen to people and then respond to them and interact with them and use the value that they bring to the system, because that's what they want. They want things to change. The second point is in relation to what we do know and what we are told about various institutions, is that we all the time, I think, need to assess what the safety implications of that information are. We should not, in my view, wait for a perceived risk to become a reality represented by injured patients, people who are not treated, or worse. And we shouldn't be satisfied with theoretical action plans. But where there is a risk, we should act before that risk becomes reality. And we should also look at information from the point of view of what it tells us about the current risk. And I think perhaps too often in the past, risk to patients is treated as a commodity in itself, which either gets bigger or it gets smaller. But no one is giving sufficient thought to the patients who are actually walking through the door of the relevant place then and there, who by and large will be blissfully ignorant of the information that an organisation like this, for instance, might have about what is going on in that institution. So I think we need to, and I know that this work is going on here, develop an appreciation of warning signs, not just evidence that something bad has already happened, but actually what are the signs that tell us that something is going wrong, and therefore something ought to be done now to prevent the damage that might occur if nothing is done. Now, in relation to regulation, as you know, I had to examine a lengthy period of regulation, different organisations being reorganised, thrown up in the air, different systems of actually working out where there was cause for concern. And while there are many ways of monitoring what is going on, really I came to the conclusion that certainly at the moment, the only regulatory game in town that actually really exposes what's going on is expert and rigorous inspection. And generic inspection, which concentrates on the theory of how an organisation might be running, looking at the policies, looking at minutes and so on, is no substitute for talking to patients, for observing wards, for having an expert view as to the capability of a service and so on. I've also emphasised in my report something which it appears to me this organisation is signing up to in spades, which is the need to insist on institutional honesty and openness. The institutional tendency has been in the past, I fear, to not to own up to difficulties within, and sometimes in unhappy cases one would say there's been actually covering up of, or concealment of serious information. And along with Sir Ian Kennedy and many others, I feel that quite often the cover-up, the concealment of information is actually a far more serious matter than whatever the original deficiency was in the first place. Deficiencies can be cured, but they can only be cured if we know about them and everyone talks about them. And the tendency not to do that must be resisted at all costs. Part of that is the need to share all potentially, and I'll underline the word potentially, relevant information with all those who can actually do something about it. One of the quite astonishing, to me, findings at Stafford was the way in which this organisation's predecessor and monitor seemed to have a different set of information, and therefore were not working together on the same basis. And that led me to make recommendations which haven't necessarily met with full favour about how the operation of those functions should change. But however those functions are to be performed, and taking up a point really that was made earlier here today, seems to me utterly essential that there is joint action to avoid duplication, to avoid overlap, to avoid gaps, and to maximise effective patient protection. And that really does require a very clear idea of what the job of each organisation is in this terribly complicated system. And then find a way of making sure patients and the public don't have to worry about that. You shouldn't have to write to one organisation and be told it's not our job, and then be told to write to another one which says, well, actually it's not really ours either, to write to a third which then takes 4 months to tell you that something can't be done for another reason. You should be able to write or contact any organisation in the health service, and they should automatically, the matter should be referred to whoever it is who is able to deal with the problem. Is that possible? I don't see why it isn't. One thing is clear, it seems to me, and I'm sure you would all agree with this in this room, is that the regulation in itself cures nothing. On the whole, regulation is there, I think, to deal with things that have gone wrong, but it can't necessarily stop things going wrong in the first place. And we have to recognise the need for efficient, conscientious and committed leadership at the level of the providers of healthcare services and of course social care as well. Without that, no regulation in the world will keep patients safe. And so I'm sure it remains, whatever I say about looking at individual cases and real patients and so on, it must remain part of your task to have a view about the effectiveness of management and leadership. And you know I have a fair amount in my reports to say about that, and I'll try not to say too much more about it today. Two other points about monitoring of organisations. One which is not always comfortable for me to say, bearing in mind part of the role of your new Chief Inspector. But we do have to guard, it seems to me, against using overall ratings as actually being a complete reassurance that everything is right in an organisation. I, as a patient, if I'm going to a hospital, might be interested to know whether on the whole it's good or it's outstanding. But what I really want to know is, if I'm going there to be treated for cancer, is how good are the doctors there who are dealing with cancer? If I'm going to have my appendix out, I want to know how good the surgeon is who's likely to undertake that. If my mother is going into a ward for the elderly, I hasten to add she's not, but I want to know what the infection rate is on that ward. I want to know how the performance of that ward compares with other wards. Now, I don't need to be able to read all that information all the time, but I do need that when I need it. And to disguise some of these the potential failings in smaller units under an organisational rating is, I think, not what's intended, but we have to make sure that's not what happens. And that leads me to a final point before going on to something, if I may say, about the Care Quality Commission itself, which is that in Stafford, as I think in a number of other places we now know, there was too much reliance on the external assessment of it as being confirmation that everything was all right, as an abrogation of the responsibility of the local organisation to be examining itself and using its own governance systems. And so I would ask you to ensure that whatever assessments you publish about places, particularly when they're good, and you should of course publish and praise good practice where you find it, that is not used as an incentive for local leaders to rest on their laurels, because clearly that is dangerous. Can I just reflect a little on what I see here at the Care Quality Commission? Firstly, to say I welcome the approach that's being taken to exploring how a set of fundamental standards might be created. And to my mind, it is essential to find what it is that brings the public and the providers, the professionals together in agreement about what it is that must be provided in every case of care, without which that care should be regarded as unacceptable or intolerable. And I think we need, therefore, to find something, and it is difficult, and I don't for a moment deny that, to find some way of expressing these things in a way which all people, patients, public, nurses, porters, even chief executives can understand, so that all can see whether or not that is being delivered. And of course, it has to be phrased in a way that it is capable of being complied with in accordance with whatever the necessary guidance is. And actually, these needn't be standards which cover absolutely everything that is done, but they are things which would be common to every form of care. And they should be things that are so seriously required that where they are not, potentially serious and proportionate consequences should follow. And I don't think I need to say any more about those here today. Candour, as I've already said, I believe is absolutely essential, and you should insist on it. And what are and what should be the regulatory consequences for failure in that regard is a matter for you. But the question I would ask is whether a provider that is not candid with patients whom it has harmed, can that provider in fact be regarded as a safe organisation? I rather doubt it. Finally, can I turn to your role as a role model? I didn't think when I started my second inquiry it would be my job to spend a great deal of time actually examining how the Care Quality Commission worked. That turned out not to be the case. And the evidence that I received did suggest that at that time a culture existed in this organisation which was an unhealthy one. And I don't hesitate to say that in this building. There seemed to me to be evidence that there was a fear to speak out sometimes about quite reasonable concerns. There was evidence of a hostility towards those who did. There was perhaps a preoccupation with setting out the good news story rather than a balanced picture. There was an approach to regulation in terms of standard and enforcement which had problems which weren't really being addressed. And not all of, by any means, of the Care Quality Commission's own making. It was challenged by having immediate demands made of it over a huge wide field of responsibility, which actually made being effective in any of those fields really very difficult indeed. And that was compounded, and this is so often the case with reorganisations at a national level in this country, as far as I can see. There was the lack of an effective means of handover from its predecessor. So that was not a very happy picture that I saw. But I believe that it was a picture that actually provided this opportunity, this organisation with a huge opportunity in transforming itself into actually being a role model, as the organisational role model for the rest of the health service. Because many of those features that I've just described were there at Stafford. they are there, I'm afraid, in other parts of the system and in other trusts. So I welcome many of the developments that I now see happening. I welcome the demonstration of a commitment to openness, albeit sometimes when it's very uncomfortable for this organisation to do that. And you've been discussing some of those things here this morning. I welcome the report about the staff experience in relation to being bullied, which has recently been published. And these are positive developments. I think the way in which the fundamentals of care are being considered openly and with the public is really good. I think that the development of an expert inspection regime under your chief inspector also sounds very promising indeed. And the recognition of the need to examine services and partner experience as well as the organisation as a whole, as I've already said, is important and welcome. What am I still looking for? Well, I wonder what it is going to be the route to immediate enforcement action to safeguard patients where perhaps consensual action is unlikely to suffice. In other words, an inspection finds something that is immediately required to be done to protect patients. At the moment, if I understand it correctly, it requires consent to do something, otherwise you have to get monitor to enter into the fray, and how long will that take is a somewhat movable feast. So I wonder what action can be done there to enhance the ability to take immediate steps where those are required. I would like to see, and it may well exist, evidence of a common understanding, approach, and where necessary, joint action between the Care Quality Commission and Monitor, given that they will continue to have separate roles. There is an issue, I think, about where individual patient cases are going to be dealt with when they show a potential regulatory breach. And I think there is some potential level of uncertainty there. But I think on the whole, if I may say so, and I'm glad to be able to say so, there is the potential for the Care Quality Commission to actually be, firstly, a role model for how an organisation should run itself and how a culture can be transformed. And I think there is the potential for it to become firstly, not only the policeman, if you like, but also the lighthouse, the warning, the beacon that warns of rocks ahead and enables and actually motivates people to make the relevant changes. So by communication of information, by effective inspection, and by the incorporation of professional experts into the work you do, I do think that insofar as regulation can make a difference, and it can, I am hopeful for the future. But anyway, thank you very much for listening to me.
Thank you very much, Robert. Any questions for Robert? Okay.
Thank you. I mean, just firstly to say that I also feel sort of optimistic that CQC is changing and will change, both in terms of the approach and the culture. So I think there are definitely reasons to be optimistic, and I wouldn't have stayed if I didn't think that. A couple of things. One is that we, as a regulator, we have said we are on the side of the patient, and that's absolutely right. That's indisputable. But I'm also conscious that in doing that, potentially we become quite divisive, and that we say, because I know we're not saying this, but just thinking of staff working in services, because potentially we're saying we're on the side of the patient, and so you're not on the side of the patient, and it's I know there's a move to look at sort of consumers, patients as consumers, and that's there's a lot of benefit in that, but it's also different because the staff working in services are there to care, and so I think we just need to be kind of mindful of what we do and how it is experienced by them generally and sort of specifically. And the morale in services at the moment is quite low, actually. But at the same time, there are green shoots, you know. I see some organisations sort of looking at Mid Staffs and the Francis report as a real sort of opportunity, and you know, and some people really have got hold of that, and that is to do with leadership. But I'm kind of conscious that particularly with the change in the system and the financial situation where cuts are beginning to bite, you know, that we absolutely must put safety first, but we do need to consider carefully, I think, how we work with people in services, frontline staff, and managers and chief execs, actually, because, you know, you could see it as that they're actually being given an impossible job at times. So it's something that we need to kind of be aware of, and I just wanted your kind of take on that, because, you know, it could be criticism, more cuts, and, you know, and how, you know, as a regulator, we could, you know, yes, be on the side of the patient, yes, take action and all that. It's very, very important, but also to be mindful of the wider context, because ultimately that also will impact on patient care and safety. The other thing is, in one of your recommendations, Robert, I think you suggested a patient's council, and we're looking at developing what we're calling a people's panel. And we already have quite a lot of involvement of people who use services in our inspections and all sorts of things, which I actually think we do quite well, and we need to do more of. But what we haven't really done so far is you know, the people that are involved are like expert patients, if you like, and they have a very valuable contribution. But what we haven't got a way of doing effectively, and I know it relates to the Healthwatch as well, is ordinary people in the street. You know, I mean, as you know, I've become a convert to Twitter, and I get endless things tweeted at me, you know, individuals, people currently detained in a mental health ward, or someone who's just lost their son in an assessment and treatment unit, you know, and it's, you know, getting that is so valuable. So the People's Panel is one idea that we're kind of thinking about how that should work. Should it be huge, or should it be a few? But alongside that, how do we get to, you know, the individual members of the public, actually, you know, who are not involved and don't know the health and social care system? Because most of the people we have involved at the moment are sort of expert user patients. Is that okay?
Well, thank you. Firstly, in relation to your first point, absolutely, the staff of the NHS need to be respected, valued and supported. And in most service industries, retail for instance, the most successful ones are those which do precisely that. There are 2 points about this I'd like to make. The first is the Care Quality Commission, in its role model, as the role model, clearly has, and indeed, I think, if I may say so, through your continued presence on the board, has evidenced proper conduct in relation to the respect to be given to people who raise concerns. That should be welcomed, not vilified. And I think that is a strong message that this organisation can give to provider trusts and others in relation to concerns that staff raise. And this organisation therefore has a role to play in supporting hospital and other staff who raise concerns within their organisations. And one way of doing that is to evidence the fact that when concerns are raised, something is done about them. And the widespread reason, or any survey will tell you, why staff are reluctant to come forward is because they don't believe anything will happen if they do, apart from, of course, being vilified. So in both those respects, it seems to me this organisation has a very valuable role to play. But it has another one. There's been much debate about my recommendations around guidance about staffing levels. So much of what goes wrong in our hospitals is likely, and indeed, to be fair, it was in many regards the case at Mid Stafford, due to there being inadequate staff, either in terms of numbers or skills. And the evidence given to my inquiry was not such as to persuade me, however, that there should be a minimum across-the-board staffing level. And I know not everyone agrees with that as a with that conclusion, but I could only act on the evidence I had, and I was, after all, only dealing with the events arising out of a particular hospital, so the inquiry, for all its breadth in the end, had limitations. However, the evidence has been put forward to me, certainly since, from the Safe Staffing Alliance, to suggest that there is a level below which it should be regarded that a service is not safe. Not that that's the adequate level of staffing, but it's the level below which you cannot be safe. Now, I haven't evaluated that evidence. I don't know what anyone thinks about it, but it does seem to me that it's evidence that's worth consideration and therefore ought to be considered somewhere, and with regard to whether there is some sort of benchmark, whether you call it a standard or whether you call it something else, which at least is rather like mortality rates, an alarm bell, which should require at least questions to be asked about whether it is possible for a service to be safe, given whatever the staffing situation is. And I just ask you to consider that as being a potential way in which to show real support for staff, some of whom are working in extremely challenging circumstances. On your second point, about patient involvement, I think this is one of the really big challenges as to how to obtain the voice that we need to listen to from patients. And there is, of course, no one answer. And I think the wider the range of measures that are taken, the better chance there is of capturing the patient voice. Every form of patient involvement I was told about in the past, the predecessors to Healthwatch, except the Community Health Council, which seemed to receive almost universal praise, if only for nostalgic reasons, hasn't worked. And the reason they haven't worked is that far too much is expected of the public, in inverted commas, in the sense that it's expected you put them in a room and give them a title, that miraculously they will become a coherent organisation which produces a useful contribution to the debate. The public should not be required to do that. I'm not saying don't try methods of that nature. And so all I could suggest is, in addition to methods such as you take, you need to perhaps go out there and talk to people on an ad hoc basis as well, encourage them to come forward and be approachable. And whether it's sufficient people even now know who the Care Quality Commission is, how they could get in touch with you, is debatable. And who can blame them? I don't know. I haven't seen Anna's route map, but if it's anything like the one that was in the National Quality Board's first report, it looks more like would look more like a load of wagons being circled by the Apaches than anything that one could understand as to how you actually sort out a problem in the health service. So I think there needs to be, from the public's point of view, simplification. And what part of that is go and talk to anyone. They'll make sure the concern gets to the right place. But there are all sorts of methods you can use, but you need to use lots of them.
Yes, I had lots of points actually now, but I'll try and be very brief. Just on that point, I mean, I hope we're already working with the third sector, because the Patients Association ambassadors, the Carers UK, Alzheimer's Society, I mean, all these organisations already have routes into the front line and experiences, and we don't need to reinvent the wheel. We just have to find a way of making sure that those people can feed into us from time to time. And that's not the total answer, but it's part of the answer. I just wanted to pick up on 2 points you made, Robert. One was about the need to avoid duplication. And in this kind of vast landscape of quangos, I do think that is a huge issue. And the Care Quality Commission is obviously trying very hard to actually reduce the number of indicators and the amount of sort of data that we require. But when you go round the NHS and social care, what is so striking is that the individual lives of frontline workers are made so much worse by the amount of paperwork and the amount of endless time people have to spend filling in forms. So I just hope we can bear that in mind, because I really think the worst thing we could do would be to, not just us, but obviously Monitor and TDA and so forth. The danger is that the response to your report will be a sort of massive data gathering exercise that ends up being counterproductive for those people who are actually trying to do a good job. And the other point I wanted to make was following on from what Kay said, really. I mean, one of the most powerful parts of your report was really explaining and describing the culture and putting your finger on that, the essence of that problem as being culture. And obviously there is a limit to the extent that a regulator can, as you say, can spot problems in advance. And I just wanted to know what you thought really about the psychology, because clearly, as I think Kay was implying, I mean, we need to be very clear, we need to have punitive action if necessary, but we also need to make sure that people who are trying to do a good job are not forced into a defensive position, because that will only lead to more cover-up. And I just wondered, I'd just love to hear a little bit about your reflections on the psychology. You know, what happens to people who are actually intending to do a perfectly good job and end up, as some of the people you found, some of you described so well, existing in their own silo and ignoring what was going on around them, and whether you think there are any insights from that that we should be using and that Mike should be using when he's trying to effectively build a new kind of culture.
As you say, a few challenges there. I agree with you about using the third sector, but I think you need to do more than that, and the reason is that, by definition, the third sector, which is absolutely valuable on the whole, will be skewed towards a particular point of view, quite legitimately, but there needs to be more than that. The bureaucratic burden, I couldn't agree with you more. Now, I have made recommendations, as indeed virtually as anyone who ever comes into this field will do, about the need for coherent information management. With a view, if possible, to ensuring that one entry by a clinician is used for multiple purposes, rather than having to employ an army of people to reinterpret the clinician's entry and into a code, which is then open to manipulation, unreliability, and all the problems that we know about. And can we please have a joined up, not a massive mega system, that even within the hospital, a joined up information system that allows patients not to be asked the same question 15 times and the same entry being made 15 times by different people. All those things seem to me to be quite capable of being changed, and in some places are. And so I would urge you to use what influence you can in that regard. But I absolutely endorse the idea that we should be very careful about what information we ask for, because and there needs to be, if possible, coordination across the quangos to ensure that they have a common set of information. And I don't think that, in the end, would be too difficult. So far as the psychology point is concerned, there are lots of answers, none of them sufficient in themselves. You talk about defensiveness, and there is clearly that danger that people, when faced with a threat of being found to have committed a breach of a fundamental standard or whatever it is, rather than owning up to it, cover it up. And that's one of the reasons I have said that the cover-up, in many cases, should be regarded as much more serious than the original deficiency. I don't think we must shy away, however, from the concept that there will be occasions when there should be accountability, possibly sometimes criminal accountability, for cases of a serious breach leading to serious consequences. One would hope those would be very rare indeed. And we talk about defensiveness. We have a system already which requires, under their codes of conduct, professionals to be open and honest in very difficult and challenging circumstances, and the potential penalties for not doing so for them are very serious. No one, to my knowledge, has suggested we should take away the GMC and the NMC's powers to strike off people who fail in their duty of candour towards patients. What I do think we need to do, however, is firstly we actually need to do more to celebrate and motivate the people who do come forward in these circumstances, and to ensure that in most cases that they are praised for doing that, rather than ending up being got into trouble for it, because it's much more important to have the information than it is in reality do something negative about that individual. Sometimes it will be necessary if safety is at risk. But one of the I hope I'm understood as having recommended, in terms of sanctions, things which actually seek to deter people from preventing other people from doing the right thing, if I can put it that way. So sanctions against harassment and victimisation of whistleblowers, sanctions against people who obstruct that sort of endeavour by, for instance, destroying documents or matters of that nature. But none of these things answer your question in full. You talk about silos, and what happens, it seems to me, is a gradual and erosive process in a place that's not working very well. And for a time, even though, however weak the leadership is, people, however poor the staffing ratios are, people will struggle on, and they will keep their idealism, and they'll go the extra mile because they came into the service in order to help patients. But eventually, things crack. And they can crack for all sorts of reasons, but one is, I'm not listened to, I really can't do this job. And therefore, in order to cope with the potential inhumanity they see around them, they go into their own individual silo and they stop looking around them. Much of what happened at Mid Staffordshire could not have happened or continued if doctors and nurses had actually looked through doors, seen a patient in their own lying in filth, and said, this is not acceptable. I don't care how long we have to stay on at night. Something must be done about this. That anger, which I'm sure we all now feel, that patients were left like that, somehow was left people. And I believe that compassion, although everyone starts off with compassion, can be crushed out of people by a system. And I do believe, funnily enough, that actually you can probably measure that. You can, well, not measure it, but you can assess it. You can smell it if you go around in the ward. And I think inspectors, perhaps, we need to consider how inspectors can look at that. But what happens then is isolation. Instead of actually reaching out and asking for help, people turn in on themselves, as do organisations. They turn in on themselves and pretend to the outside world everything's absolutely fine or normal. And it's the same thing happens on an organisational level as it happens on an individual level. So you need as many ways as possible of seeking to prevent places turning in on themselves and becoming isolated. And we can do that through peer review, clinical networks, making sure that staff are continually being not circulated out of departments, but circulated into contact with people from outside, so that they have a means of finding out what's going on outside, importing it into their organisations, but also telling other people about their concerns. Just to give an example about where there should be more informal reaction, the senior registrar in A&E who went to his college meeting and described to them what was going on in the A&E at Stafford. What happened then? Well, they all expressed concern, they all expressed sympathy, but there must have been senior colleagues there. What did anyone do about it? Nothing. Well, that sort of thing goes on everywhere. If the professionals in this field decided to get together and help each other, many of these problems will be sorted out long before they ever got near your organisation. And I do believe that there is something about the commitment that comes with professionalism that somehow needs to be reinforced as the real means of ensuring that the cultures do not slip into this dark place that they have. That's not a complete answer, but it's some of my thoughts around this field.
Michael, did you want to comment on this? You've looked at this concept of a just culture a bit, which might be interesting. You need to press your button, actually. Yeah.
I think colleagues will have seen in one of David's letters to CQC staff that a reference to something called the just culture or a just culture. I had never actually, embarrassingly, heard about this before. So I Googled it, and of course it turns out that there's a huge amount about this. And it actually originated in aviation, which of course is another sector in which safety is absolutely paramount. And the central idea of just culture, I mean, David, correct me if I'm wrong, because David attended a presentation on this, is that it's a culture in which worry is a good thing, and a positive or a true just culture is a culture in which maybe whistleblowing is not quite the right term, but raising problems is the sign of a healthy culture, as opposed to the sign of a problematic culture. But it does, to take Robert's point, recognise that there will be decisions taken which are completely unacceptable, unprofessional, or just simply completely flawed, and those need to have consequences, and some kind of punishment may not be the right term, but something has to happen as a result of those decisions. So it has a sort of a gradation of how to react to actions in a system designed to promote safety. And I was actually very taken by the idea of a just culture, and part of the result of Googling is it turns out that some very important, I mean, apart from aviation, some, I think what would to the outside world be world-leading hospitals like the Stanford Medical Center or the Stanford hospitals have adopted a just culture. And I think the Harvard Medical School now teaches just culture as part of its program for training doctors. And it may be that at the next, one of our next meetings, that David perhaps could take us through the presentation that he saw on this, although there is, as it happens when you Google, a sort of a standard presentation which I sent to David, which the creator of a just culture gives. And also building on Camilla's idea, I think as part of the inspections, and I'm sure Mike is doing this, some sort of culture audit, and that is a terrible term, but I think we know sort of what it means, should be an important part of an inspection of a hospital. And it may be, to take Hayes' point, that the culture audit is something in which either expert patients or members of the community should perhaps be particularly good at being able to understand. I don't know. But I do think this idea of being more certain that the culture is right, I feel is important to the inspection process going forward. Now, I actually had a particular question for Robert, which I hope we've got time if I can just ask it. And it's really, I'm asking it in this new role of mine, a new role, I suppose, of colleagues around the table, which is about non-executives. Because Robert made, I thought, a very important point, that the non-executives in Stafford had an idea of the borderline between non-executives and executives, and were concerned about overstepping that border. And perhaps the executives influenced this idea of where the borderline was. So I'd be very interested in, Robert's reflections on that. And I don't, expect him to say where the border is here at the CQC, but I think it would be very helpful guidance, certainly for me, to get a more understanding of that.
Thank you. Just a word of mouth about just culture. I, of course, had a seminar on culture, and and culture came into a number of our seminars. And what you say about the aviation is also, I think, true of the nuclear industry. And there we had a presentation from Chief Executive of a large nuclear company, who spends a lot of his time talking to junior staff on the floor of nuclear plants, hearing what their concerns are, welcoming those concerns, and ensuring that what he does about them is communicated back. And if he finds it's not unfounded, he still thanks them, and will explain why it's unfounded. Retail is the same. One reaction I got in the room from fortunately I can't even remember who it was, but it was clearly a relatively senior figure in the National Health Service, was, well, it's all very well talking about selling televisions or that, but the NHS is different. And the answer, of course, is that it's not different. I mean, if you're in the business of saving lives and making people better, then the least, it seems to me, you can do in relation to your culture is at least do what they do when they're selling a television set. You may need to do rather more, but it's it doesn't. There is this culture in the NHS that we are different. We know what we're doing. We're special, and that I fear needs to change. And can I just mention one in terms of cultural audit? You're right. There are, I believe, various people developing tools which might be used, and one of them is being developed by a group of nurses. Is called the Cultural Barometer, and you might want to think about measures of that nature. Turning to your point about non-executives, you're right that what I found was, to my mind, a quite astonishing rigidity, whether more rigid in retrospect than it was at the time, I don't know, but rigid in retrospect to explain why various things weren't looked at, between what they regarded as strategic, which is what a non-executive director could concern themselves with, and operational, which they couldn't go near. And so reports on an individual incident of a patient death caused by systemic failings would not get to the board because it would be considered to be operational, not strategic, and that seemed to be perfectly all right so far as the chair was concerned. So there is, whereas of course, even if you do take that division and one can see some sense in it as, in theory, what is operational one day can become extremely strategic the next if you can bring down your organisation. So you need, on every case, it must be a matter of judgment. So firstly, I think I would suggest, if I may, you need a discussion about what it is the remit is, but whatever that remit is, make sure there is some flexibility there, and the judgment about the flexibility must be on the side of the non-executive directors, not on the side of the executives. The second point is, I think, a matter actually of expertise, and many, and I'm not going to talk about this board, but many boards of NHS trusts and foundation trusts on the non-executive side, quite understandably, have a lot of people who come from a business background, or people who, for whatever reason, really understand balance sheets, accounts, and so on. So it became it's much easier for them to talk about money than it was to them talk about the ethereal business of quality, particularly in fairness to them at a time when quality was a brand new concept in the NHS and no one quite knew what it was anyway. So there's the fact it's easier to understand a balance sheet of money than it would be a balance sheet about quality would mean that they would contribute, I think, more in that field than the other. So advice I would give, certainly in relation to NHS trusts, would be please make sure that your directors, insofar as they don't have expertise in these fields when they come, and they may well not, they get sufficient support to understand these rather more ethereal, novel concepts and how they can contribute in the challenge required on those matters. And the final point is, and I've learnt this to my benefit through many years as being a barrister, is the fundamental rule in almost any sphere is do not be afraid to ask a stupid question, because almost invariably it's not stupid, and it's not stupid if you need the answer to it, and if you don't get an answer, carry on asking the question. That would be my tip to any non-executive director.
So I was very struck by what you said, Robert, about the opportunity for CQC to role model. I'm particularly struck by it because actually it's my experience that usually the regulator mirrors the sector it regulates, and that actually this is a challenge to change it sort of through role modelling in a way how the sector behaves. And then I was thinking about the centrality in what you say and in what the Davids were saying, and kind of linking up with what Kay was saying of putting users, consumers at the heart of that kind of new model, and the importance of listening. And I know that in our thinking about inspection, thinking that Mike's already doing, we're talking about how to capture local intelligence from users of service to help inform that process. But I wonder if we might not take something that I think what you remarked on, which I think is as being really good, and I also think has been a really good thing, is the bullying report. So if you like, what we did with the report on bullying inside CQC was create an explicit listening environment. And I wonder whether there isn't something that we could take from that as a bit of good practice, if you like, and take into our inspection activity, perhaps not just for hospitals, but kind of in the round, because people's experience is in the round, and think about how we could ask CQC inspection teams at local levels to create listening events in order to pick up what's happening as a matter of routine. I mean, not just when they're going into a particular, but just to create that intelligence. And I wonder if we did those sorts of things, it might not rub off on the rest of the system, because I think you'd find that the other providers would want to come and listen too if you were organising it, and it might have an immediate impact before we even needed to go in to inspect. So the kind of notion, I mean, I'm sure there are many other examples, but this notion that actually we think, well, how could we do things differently, both in our own activity at a national level, but also through the inspection regime, and kind of challenge the way that other people are doing this, I think is really quite I think, powerful idea. Immediately made me think of one thing, but I'm sure there are many others.
Thank you. And if anyone else, yes, would you like to, David?
Possibly members of the public could contribute. Also, because you've encouraged us to ask stupid questions, I hope this is one, but anyway. I'm very interested in your idea that we should get away from generalist inspections. CQC should get away from the generalist inspections. That is to say, if you mean by that looking at in the files, finding a policy which says that good care happens, and then assuming it does happen, which does seem to be happening to some extent. What I'm worried about, I think, is the concentration on users, which may work, and obviously has worked with Morecambe Bay. But in the quest for home care, your own report, which I think you commissioned, excellent report, makes it very clear that a lot of older users, and of course dementing users, find it extremely difficult to make any kind of complaints or to tell the truth. Maybe they don't even know what the truth is about the care they received. And I think particularly in the area of home care, there is evidence out there, particularly in the electronic monitoring reports and in the timesheets, which will tell you a certain amount about quality, about things like timing, missed calls, changes of carer, and maybe give you some sort of indication of what might be happening in the other things which can't be monitored in this sort of way. And I would hope that the CQC might pay, so far I found a certain reluctance to this, should pay rather more attention to using every bit of evidence in these of this kind, where user feedback is so difficult, is so unreliable, and so hard to get.
Thanks very much, David. Robert, did you want to respond to that, or?
Well, I can't, in my capacity as chairman, respond to the business about home care, although that's a hugely important field and clearly needs to be considered. But I think I can say something about vulnerable patients. Of course, whether it be in hospital, in care homes, or at home, there is this vast population of vulnerable people who really can't speak for themselves, and many, unhappily, don't have families who can speak for themselves. And one of the thoughts that came from witnesses at Stafford was in relation to sitting there dealing with their own families, patient relatives' problems with the care, what's happening about those who haven't got someone sitting by their bedside. And I would urge, and I hope I've urged sufficiently in the report, that consideration is given to how you give a voice to those who can't speak for themselves, and to ensure that their care is looked at in exactly the same way as those who perhaps can speak more loudly. But I agree with that.
Camilla?
Just to say, I recently completed a review of care workers, and I know the Department of Health was looking at whether you could introduce a friends and family type test for those people, and of course there are very, as you said, there are very big issues with it. Partly, you know, when do you trigger it? Because it's an ongoing relationship. People are very nervous about making any kind of complaint. But the other thing that struck me was that you can get quite a lot of information from home care workers themselves, and actually from Unison, the unions. And I mean, that's just a point really, that I think if we, across the board, are going to be better at hearing from staff, we might just want to think about that, because I mean, there are about 500,000 people, I think, aren't there, who work in that sector, some of whom are constantly moving between agencies, and some of whom probably actually give you some quite good insight into what's going on.
I'm Robin Pike, I'm representing Hertfordshire Healthwatch. I wonder, Mr. Francis, if you could perhaps elaborate a little bit more on the complaints side of the NHS, which you referred to earlier, and the complexity of the current complaints procedures, and how somehow the NHS has an ability to subvert, to avoid any changes that come in to a complaints procedure. So we have an NHS constitution which has been revised. It speaks specifically about the need, for example, to acknowledge a complaint within 3 working days. That is widely ignored by hospitals, I think, and complaints are, in the experience of patients, are just widely ignored. And what is it about the culture of the organisation that whatever changes are introduced, there's some way around responding?
Well, one can say it's human nature becomes cultural nature of avoiding issues, and it's partly it. But actually, I think what I've said in my report about complaints is, firstly, they are the absolute gold dust in relation to an organisation itself learning what it needs to do to change. Therefore, any organisation which is ignoring or downgrading complaints and not responding to them properly is almost certainly either dangerous or on its way to becoming dangerous. That's the first point. The second point is that there should be, in my view, a greater level of independent scrutiny of complaints. And I don't mean by that this body or other bodies should take over the running of the complaints. That clearly should, in almost all cases, remain with the provider. But firstly, there is a category of complaint where it should become far more routine than it is at the moment, where the investigation of it is actually done independently. It's quite unfair, it seems to me, quite often to expect the relevant senior staff on a ward who are implicated in a complaint to investigate it themselves. They won't know how to do it. The next point is that we need transparency about what happens with complaints generally, so that local Healthwatch, the commissioners and everyone else actually interest themselves not only in numbers of complaints, because actually the more complaints there are, in one sense, that doesn't tell you whether the place is good or bad. It's actually what's in those complaints. And what I found, looking at complaints, was, again, individual cases or a collection of individual cases can tell you an enormous amount about what's going wrong in either a ward, a hospital, or a service. And so I believe that the stories of those complaints, suitably anonymised, should, and you may well need the complainant's consent, but I don't see why that wouldn't be given in most cases, that there should be more publication of those stories. Lots of this now turns up on websites and so on anyway. And I think that if you publish those stories, the message gets back to staff. One of the problems, I think, is that if you just give staff and everyone else figures and trends and so on, they don't actually connect all that with the impact it has on individual people. Whereas if you and they end up not believing that the complaints are serious. There are people in Stafford who still believe that their hospital has been unfairly described in the past. I'm not commenting what it's like now, but what it was like then. And even though they've read these complaints, but I think if they actually read what people have gone through, they would find that much more difficult. And it impels people to do something about the problem. But one sort of more boring point, I think, is that those who are employed to deal with complaints in many hospital trusts are undervalued, undertrained, and generally under-resourced. With the result, it's inevitable that they breach the deadlines required. It's inevitable that a lot of complaints aren't dealt with very well because they're not given the priority by the organisation they should be. This is really important information which can actually end up meaning the difference between patients being treated well or patients being treated badly in the future. So any organisation must be on top of its complaints.
Thanks. I mean, time is moving on. So Paul and Mike both wanted to say something, and then I think we'll probably have some coffee. Paul.
Thanks, David. To Mr. Hogarth's point about home care, and I think you exposed one of the hardest sectors that we have to regulate. And you're right, obviously right about the patients who have dementia, for example. I think the way we have to frame this, though, is we are probably not going to get the fullest picture in that sector. It's because of the complexities associated with it. But the way that I think we need to then frame it is how much better can we get than where we currently are, and progressively better on a journey. I was concerned that you'd picked up, I think you've been at a number of our listening events as well, that there might be a resistance to using other forms. And I would definitely want to pick up on that, because we should absolutely use other forms if we can't be confident that the user voice will be in any way sufficient. But I do think it's extremely important for us to make progress on this and not be put off by the fact how difficult it is. Yes, I'd like to. Thank you. To Robert, we had quite a conversation about the role of us as regulators and some of the interplay with the other regulatory bodies, and also a lot of discussion about the providers. I wondered about how you saw our interplay with commissioners, given we have legitimately overlapping but different roles, and particularly the allocation of resources role that they have and that we don't. And some of the things I think are easy, like the transparent information sharing, but I think some of them are significantly more difficult challenges. And I wondered how you saw the balance of sort of risk and opportunity in the way that we choose to work with commissioning boards, CCGs.
Well, firstly, can I say I think a message from my report would be that if we have commissioning must be taken seriously, and a complaint by a patient that they've been badly treated in hospital is in part a complaint that the service that's being commissioned hasn't been provided. Therefore, it is a responsibility, I think, of the commissioner to, where necessary, take up the cudgels on behalf of the patient. And I don't mean there's an appeal system and all that sort of bureaucracy, but that to take up the cudgels to ensure that the complainant is being looked after properly, and B, that the trust is actually doing something about the substance of the issue that the complaint raises. Now, I understand that it may not be practical to do that, to provide a sort of individual service for absolutely every patient, and there needs to be some sort of selection process. But that could be either dealing with it on a random basis, or you can grade things so that it's the serious complaints that you give priority to making sure are dealt with. But I do believe that commissioners have a role, if necessary, to intervene in order to insist that the matter is dealt with properly. And that's not an appeal, it's not a revisiting of the complaint, it's actually using their powers as commissioners to ensure that the service that they have paid for is actually being provided. What does the Care Quality Commission bring to it? Well, firstly, the intelligence that exists within the complaint. The information, it seems to me, is again gold dust to the Care Quality Commission. Again, it doesn't mean that you can, David Bean here can examine every single complaint throughout the country. That's impossible. But your structure of intelligence, your structure of inspections and so on, it seems to me should actually embrace the information that's contained in the complaint. Interaction with the commissioners, share information. And if what I was saying earlier about assessing all the time the impact in relation to patient safety of information you have applies particularly, it seems to me, to what you find out in relation to complaints. So in the sharing of information, it needs to be part of the function of the Care Quality Commission and the commissioners to be looking at what does this tell me about how safe this place is. And if it may be, it's saying this place is actually, that ward is absolutely dangerous this very minute. We need an intervention. Because if actually the intervention took place in relation to complaints, you'd never get to having to be alarmed about mortality down the line, if you see what I mean. So I can't tell you how you do that, but it seems to me that's an approach that perhaps should be considered.
Happy to cover my point in my presentation.
Okay. Robert, thanks very much. I've long argued that your report is a seminal one, and I think the service that you continue to perform by articulating it clearly and simply and thoughtfully, as you've done this morning, is a tremendous service to the public, to professionals, but I think to us in the way that you've bespoke your comments this morning. I'm grateful for the reflections which are supportive. I'm equally grateful for the reflections which are challenging as well, and of this unfinished business that you've flagged up, and maybe David, that's what we should draw attention to. I think on the joint work, I think there are meetings this week with both the TDA and Monitor on Friday afternoon, which is really pushing into this challenge that you've issued about how we can work with both of those organisations and make sure that we have got systems and processes in place to exchange the information and actually make these decisions. It's work which is going with good grace and support, but it's work that needs to be completed and isn't completed. On enforcement, I think we need to take that away rather than we've got a ready answer to this. It's something that we're acutely aware of. About what powers we're left with that we can take immediately and what, as you said, have to be negotiated and agreed. And there's further work to do on that, and it would be wrong to suggest that we've landed that. I think your point about individual cases, which has really gone from 9 o'clock this morning to this particular point in time, is really something that we'll pick up in the design of the methodologies. I'm personally convinced that we do need to be speaking to people who are ordinary service users, not just the normal groups which represent them. We do have arrangements with the Relatives and Residents Association and the Patients Association who get cases on their helpline and refer them through to us if there are systemic issues, and we have a contract with them to do that and are considering extending it to the Carers Association to get that similar formal arrangement. But I think this point that we were exposed to speaking to the families in Morecambe, David, is one that has really landed. So I personally think we need to speak to some complainants and whistleblowers as part of our inspections. Not all of them all of the time, but to do that, and we are looking at how we do that. I love the metaphor about a lighthouse rather than anything else. I thought that was powerful and to the point and picks up. So, Robert, thank you for that. What is item 3, David, and I'll do this very briefly, is a report which is a more formal response to the recommendations that Robert made in his report. There are 36 recommendations which were directly to us as CQC, and a further 73 where we need to make a contribution to. The annex goes into some detail of where we're up to in terms of the report. I'll not present the detail, David. Safe to say that what we are attempting to do here is identify how this work is embedded into the work we're doing to redesign our hospital inspection methodologies and the approach that we're taking. That's a transformational change we're trying to make, as opposed to chasing down 109 separate recommendations. the issue I think we're trying to grapple with here is how far can the detail of those recommendations be embedded in the transformational changes we are taking. So the strategy, the business plan and the work we're doing around transformation are really the vehicles that we're using to take this forward. We will track every individual recommendation, David, and we're committed to providing a further detailed report in November that will allow that transparency with Robert's original recommendations and how we take this forward. We also contribute to a group that the department's running on patients first and foremost, because there's a collective agreement that we've entered into with the department that will support the publication of something in the autumn. Further work on this is, I think Don Berwick publishes report next week, and we'll expect his recommendations on safety and for the government to consider, and on this important point that has resonated through the morning, Clwyd and Hart and their recommendations. We understand that that's due to be published in September of this year, and so there's I think Paul was making this point at dinner yesterday evening, there's some further work that we need to do to consider those recommendations, but I hope the board can accept the report. I think it's appropriate it follows Robert's conversation with us all this morning about the progress we're making. I'm really pleased that this has been webcast this morning, because it can then be a record of, I think, a very clear conversation that you've helped us through, Robert, and I really hope as many of our staff as possible can actually spend some time having a look at the conversation that's followed this morning. But David, thank you. Thank you, Robert.
David, thanks very much. Robert, thank you very much for coming this morning. I think that I think your report will be the seminal report on the NHS, actually, because for so long we've accepted the NHS as an iconic institution that is almost beyond criticism, and that actually to criticise the NHS you sort of felt bad about yourself. But actually, if we don't have the truth about what's happening in the NHS, we won't have trust in the NHS. And I think, sort of paradoxically, the robustness of your criticism is the best hope in restoring trust in an institution that we all feel very strongly about. So we hope we can carry on, putting into practice much of what you've said in your report. So thank you very much. And I think we'll have a break now for coffee. Thank you.
Okay, thanks, David. So I'll spin through this pretty quickly. First point I want to pull out is, with Mike having arrived, I've previously asked you to agree delegations, and some of the judgments we need to make about actions against trust we're now handing over to Mike. That allows me to step back from those decisions, and I can then be the first point of any kind of appeals and refer them to you as appropriate. Item 2 I'll just keep out of. Mike will report on that when his report comes up later. There was a question earlier, Steve was raising this, about the use of Section 48 powers in relation to the Deloitte's report. Well, because of some changed arrangements in relation to safeguarding inspections that Ofsted have introduced, those joint inspections with Ofsted have now been stood down pending further work that we will undertake with Ofsted. But what that means is we need to continue to undertake safeguarding inspections of healthcare services. And in order to do that, we need to be clear about the powers. The powers we're going to use is Section 48, they're the powers of investigation. In order to use these, we are required to consult with the Secretary of State. We've done that, he's approved that, and what I'm effectively doing here is notifying you that that's the case.
But in the last sentence doesn't finish.
So this was spotted by my good friend Bren, who's arrived from Gloucestershire Healthwatch. It's a gathering of Healthwatch people here, and so there was an amended one that was sent out. So the rest of the sentence is, It's great when members of the public are correcting your reports before they've even been considered. I expect this to be an interim arrangement until CQC and other inspectorates are in a position to introduce multi-agency inspection. Apologies. Transformation programme, there's a seminar later this afternoon for board members. We've updated the Grant Thornton review, just drawing the board's attention to the further work that's going on around extending the size of the board. In 7, we've covered in the previous discussion the fact that People Opportunities have published their report. We published it last week on our website, and there was media interest in relation to that. I think Robert's already drawn attention to it. What is important is, just to pull this out in 7.3, that when I considered this with other leadership colleagues, I think I went into that meeting thinking the outcome was an action plan. What was clear in the meeting is that was the worst outcome we could have got. The right outcome was a conversation across the organisation with the senior leadership team making some commitments about how it's going to behave differently. Without going into some personal stories, there are a number of people in that leadership group that were moved to tears because they felt they'd been complicit in a culture that was difficult for them, that they didn't feel that they needed to own, and was a signal, I think, of some people beginning to make personal journeys and personal movements as we move forward. So what we're looking to do is create a discussion forum on what is the culture we wish to create in CQC by engaging the broader staff and leadership community in that conversation. And Hilary and Sarah Hunter will do some more work which picks up on the conversation we were having earlier about a just culture and how we move that forward. The thing that I'd add to what Michael said about the just culture is the just culture is not a no-blame culture. It is a culture where people accept responsibility. I think that puts your point, Robert, about professionalism and professional responsibility. But it is a culture that accepts that sometimes we just make mistakes. The issue is distinguishing between human error and people being reckless in their behaviour in the way that they actually ignore risk and the judgments that they make. So that's the key issue. And we want to form that as a piece rather than keep it separate. And then the theme of joint work with others, there's just some updates on important conversations taking place which result in memorandums of understanding with the Trust Development Authority, a practice framework with a GMC which really says if you're a GMC member of staff or a CQC member of staff, this is what you do when you meet these circumstances. Which is helpful, and then work with the Royal Colleges that David, you and Paul, as well as Mike, have been involved in. So good progress being made on that. And then the last paragraph is just to update you on appointments. Mike's appointment, which has been much trumpeted, but Andrea Sutcliffe has appointed and has been at 2 meetings this week, even though she's probably not going to be released from her current job until September, October time, helping us with particular issues, either with ministers or in an internal meeting this week. We interviewed for the Director of Corporate Services, and we just need to confirm references prior to announcing the successful candidate for that. We have an appointment to make, and I'm confident the references will be positive. And then tomorrow, David, you and I and Anna and Professor David Haslam will interview for the Chief Inspector of General Practice, and we'd be optimistic there's an appointment to make there. So I think once we've completed that, that will be the 6 members of the new senior management team appointed, and not quite with us, but nevertheless in post. So so we'll go on our holidays with a new board and a new executive team appointed. Thanks, David.
Any questions on David's report? Okay.
I understand that the first tranche of the friends and family tests have been published, and I just wondered if we're sort of connected in with that, part one, the intelligence, but also how it might be useful to us, in the future as part of our, surveillance.
Yep, came out yesterday, I think at 9:30, if I remember. It forms a central part of our intelligence, or I should say it will do. So it was the first 3 months of data, decision made not to publish it after the first month, which was April. but we do also have the year's run of the Midlands and the East data, because they effectively piloted it from April 2012. We just need to use it. It's as simple as that. That there is a moderate correlation to things like mortality. It's by no means 100%. You wouldn't expect it to be. The whole principle of our surveillance model is not to just focus on one indicator, but to pick out the ones that genuinely matter. My hypothesis that friends and family will be one of the ones that genuinely does matter, but we need to play it into our model.
So is it just a case of us using the information, and that's... So we just get... The information is just is passed on to us, and then there's no sort of... in terms of how it might be used in the future, how useful it is, or... the actual test itself and how it's used.
I think there are three bits, Kate. So I think that there is the part that we get. It goes via the information centre, if I'm rightly, and then comes to us. We don't see it before others. But then there are two other elements. One, we can then feed into the process and do as to what's working well and not well. There's a legitimate concern, I think, out there as to whether the data collection process is sufficiently robust across all trusts to allow a comparison. And we continue to play into that on a national policy level. The other part, because there's the free text box, which and a lot of people certainly have used that in the Midlands and East. I haven't seen the proportion of people who are using it yet nationally. That gives us the potential for a very, very rich source of data, which when we go in and do the intensive inspections to really pick up people's positive comments, but also concerns about at ward level and within the A&E. And it rolls out for maternity from October.
And just to say, I've seen it in use in the Midlands and East on various wards, and I think our inspectors, as they go around the different wards, it'd be very interesting to see, have they openly put up what their results of their friends and family test are, have they put up examples of the free text comments from individual ward levels. So that's certainly happening in Midlands and East.
I had a question on paragraph 2, but do you want me to hold that over to Mike's report?
Do you want to do your report then, and then...
Very, very happy to do my report. Thank you, David. Just first of all say I am absolutely delighted to have joined a CQC. It's a huge challenge, but I'm really looking forward to it and already into it. As many people will know, I took up my position on the 16th of July in parallel with the publication of Bruce Keogh's report on the 14 trusts with high mortality. And on the same day, the Secretary of State asked us as CQC to start the hospital inspection programme next month, so no pressure there. And so 2 days later, on the 18th of July, we did publish the approach that we are planning to take for the first wave of trusts, and we named the 18 trusts that we were going to look at. You'll all have seen that, but in essence, based on the surveillance model that has been developed by CQC, we identified 6 trusts that were at high risk, 6 that are at low risk, and 6 that are somewhere in between. And we think that that will give us a really good spread to see how our inspection model works, and indeed how the surveillance model works. The approach that we're going to take very definitely builds on that developed for the Keogh review. 3 separate steps. One, a very important step of preparation before we go into any trust, using the surveillance model and looking at that to see what it tells us about is a trust safe, effective, caring, well-led and responsive. But equally alongside that, the local data gathering. And that will be local data that we ask from the trust, from the commissioners, from Monitor, TDA, Healthwatch, anybody that wants to provide us with information at that point. And I think that's where complaints will be one of the key issues we will want to look at there. And we won't simply want to look at the number, although that's a starting point, but we will want to look and see whether the trust has done any work on identifying themes within the complaints. Have they identified the particular areas of the hospital where they seem to be getting most complaints? How do they handle the complaints? And we'll go into this more when we go to the site visit. Who is it that deals with them? How, to what extent, I previously was a clinical director myself at Guy's and St Thomas's, and in general I found that the easiest way to resolve a complaint was to see the complainant as soon as possible. Fortunately, we didn't have very many, but that was certainly my practice, and so I don't think it necessarily always has to escalate to the chief executive of the trust if it can be resolved at before that. So I think we will definitely be looking at that and gathering that in the data gathering phase. The second phase of the process is the site visit, and we've already said that there will be both announced and unannounced components to that. And I think the advantage of the announced component is that we will be able to expect the relevant people to be there, unless there are particularly good reasons to the contrary. We will expect them to have got the documentation ready, but very importantly, it will allow us to hold certain key events alongside. First and foremost, a patient listening event. So if we know that in early September we're going to go into a certain trust, we can announce almost now when the patient listening event will be, make that knowledge available in the local press so that people can be there, and then the panel can hear the stories from whoever in the locality, good or bad, that they want to tell us about what's going on at that trust. Equally, with an announced component to the visit, we will be able to ensure that we have focus groups with staff set up, and I think these prove to be a very powerful part of the KEO visit alongside the patient events. So a meeting with junior doctors, with consultants, with junior nurses, with more senior nurses, with allied health professionals, and I think it is quite important to get them in those groups so that the junior doctors are not being heard by the consultants who may write their reference, but they can then tell us what really is going on. And the junior doctors often know. First of all, they move around the whole hospital, but they've also moved from other hospitals locally in the recent past, so they can do comparisons. And so they are a very valuable part, and we will have junior doctors on our panels as part of this as well. We will take large panels into these trusts. Part of that means we don't have to be on site so long. We can divide into groups. Some will go to maternity, some will go to A&E, some will go to the frail elderly ward, whatever. But then we will triangulate and find out what everybody is finding out. We will always go to certain key areas, and we've already listed what we think are some of the core areas where the highest risk exists. Accident and emergency, the medical emergency medical pathway, the emergency surgical pathway, orthopedics and trauma, critical care, maternity, paediatrics. We will also always look at end-of-life care. But then on top of that, we will be able to go into any other area depending on where concerns have been expressed, either through the patient listening event or through complaints, whatever it may be. We will also always have an unannounced component to the visit, but having had the announced component, we may well have heard from, let's say, from junior doctors that the problems are on a Friday night or a Saturday night when the staffing levels are low. Well, we might then choose to go back in on a Friday night or a Saturday night to see what's going on. And then the third phase of the inspection is obviously a report. And that report will be ours, and it will in due course lead to ratings. We can come back and debate ratings, but we are committed to giving an overall rating for the trust, but also to rate the safety, the effectiveness, the caring, the responsiveness, and well led. I would also like to get down to the level of rating individual services. Jennifer and I have discussed this many times. Your example of cancer services, Robert, I would actually say you need to go further than just saying cancer services. It's the breast cancer service or the colorectal cancer service or the lung cancer service, and I know from my previous experience that one can be a whole lot better than another in an individual trust. So that's the process. We will no doubt develop this and modify it as we go on, but through wave one. We have, at the same time as the announcement on the 18th, people will know that I suggested that we might need a small army of people to help us with these inspections. I've been extremely gratified by the response, where I think it's over 3,000 people have now responded, roughly speaking half professionals and half members of the public, often patients or carers. And I think what this tells me is that people do want to see the NHS get better, and they're prepared to help us in that act. So I'm very encouraged by that. Just before I finish, to say we are taking forward work on mental health as rapidly as we possibly can. We're starting one stage back because we don't have the KEO review process to build on there. So instead of that, what we're doing is co-producing our approach with a whole range of different people in the field of mental health. That is well underway, and some of us met with colleagues at the Royal College of Psychiatrists just over a week ago. There have been internal meetings. There's an external reference group that I will now be joining, and our plan is that during the autumn we will have our proposed methodology. I think a lot of the principles will frankly be the same, but the application will be different because often mental health trusts are on 10 different locations. We will have to do things, and the services they provide are obviously different. So we will hopefully go out to consultation later in the year on our approach to mental health trusts, and then early in 2014 I would hope that we would at least be piloting an inspection, and then with the distinct aim of catching up so that there is parity between mental health and acute services in our approach, with the aim that our first round of inspections of both, I would hope, would be completed by the end of 2015. We haven't formally decided that, but that seems a good objective to me. Thank you.
In referring to the 11 trusts out of the 14 in the KEO reviews, they're in special measures. I just wondered, if we're now going to take ownership of those 11, does it require a re-inspection before they come out, a complete re-inspection? And have we thought about that? And presumably, in the new round, we will have the same sanction. I'm not trying to prejudge any of them, but in some cases, there may be some that go into special measures.
Yes, in terms of all 14 trusts, we have already committed that we will do a follow-up inspection. Now, the exact nature of that inspection we haven't yet committed to, but we have said we will do this within the next year. What I plan to do is to go back through the 14 reports and action plans that came out of the KEO review. Those actions have timescales against them. We know who is meant to be leading on what. We can then decide when is the sensible time within this next year to go back into those trusts and to see whether they really have made the changes that were recommended. So we are committed to that. Yes, I suspect that we will find more trusts that may need to go into special measures. I can't say that, but it's quite possible. And if so, again, we will be working with Monitor or TDA, depending on the nature of the trust when we go into it, in terms of that action.
So the expression special measures is within our existing powers?
To the best of my knowledge, special measures is a new term to the NHS, and I don't think it has any particular standing as yet, other than it's been used.
I think that's absolutely right. It doesn't have any legislative basis in the same way that, say, does Frosted. But what it has meant for those 11 is that it's they're now subject to a governance review, and I think that's important from the way in which we look at them in the future, because we'll be looking at their well-ledness. Well, Monitor or the TDA will have to first complete their governance review and decide whether the senior leadership is the right senior leadership for the future.
It's not legal, but if you look at the care bill has an escalation process of concerns in relation to hospitals, and failure to come out of special measures when we re-inspect in the care bill triggers automatic consideration by CQC and Mike on our behalf that the next step is administration. So that is a formal process, and the care bill will give legislative event to this. So one needs to look at the language that's being used on these trusts in the context of the plans in the care bill, where the care bill has a three-stage escalation process in relation to failure, in relation to any trust, whether they're a directly managed trust or a foundation trust.
Two things. The second, I think, touches on that. The first is that there is a very, very large mandate behind these inspections. It's impossible to overestimate. If you look at what was said in Parliament, and if you look in a sense the direct response after the Francis report, people will be very interested in what they say and how they say it. These will be sizable events in the autumn, and we need to know that as they hit, there will be a rhythm as they come out. And the second thing is, because of that, what happens next will become as significant as the inspections. And what happens next is not so much in our power as in the power, if you look at your report just a couple of items ago, and item 12 about strategic partnerships, there's a lot of discussions going on with the TDA and with Monitor and with others, and in the care bill, about a set of outcomes. And before the first report lands, we need to be clear about what that rhythm is, because the report will be brilliant. Note the change from the may to will there. The report will be brilliant, but the outcome of that report is what matters, and we are still, in a sense, in negotiation with others about what that means. You know, what does the TDA do? What does Monitor do? What do we then do in response to what they do? And if there is a thing called special measures, which then leads to administration, then that becomes a different sort of road. I mean, Robert, it's a really interesting thing at the moment that it may well be that Mid Staffs closes because of money. That's the only administration at the moment. So where we have a report around quality which shows a catastrophic hospital, but actually it all closed because of money. And some way down the line, there will be a closure because of quality. There will be an administration because of quality. And that's part of the rhythm. I'm not saying that's the only part of the rhythm that I think we need to get into. So there will be a lot of expectation on these inspections, but there'll be more on the things that are as yet unfinished in the system. And that all of the, I think David and Paul need to, get those discussions with strategic partners really clinched.
Thank you, Paul, for saying that the reports will be brilliant. I think what I didn't particularly say is that in the third phase, the report back phase, we are also proposing to hold a quality summit for each one of those. In the KEO process, this was always called a risk summit, but then he was looking at hospitals that all had high mortality, and we hope that we're going to find some hospitals that are really very good. But a quality summit at which we will present the report from a CQC angle, but we will have either Monitor or TDA together with the trust, local Healthwatch, the commissioners, etc., present, and that it is at that meeting that an action plan has to be hammered out with clear responsibilities for who is going to take things forward and within what timescales, so that then CQC can know at what point we will go back in, because we will know that the action should have been taken, let's say, within 6 months. So that's how I envisage it working, and I've certainly talked to both Monitor and TDA and commissioners about that, and they seem to think that is a reasonable way forward.
I'd also ask one question. As a clinician, if you make a mistake, would your advice be to other clinicians to go to the patient immediately and say, I have made a mistake?
Yes, it would, and I think that is something that we were not brought up to do as clinicians, we have been far too tardy in doing that in the past. But I think the mood is changing. as always, the mood perhaps doesn't change as quickly as one would like it to do, but I think there is now a far greater emphasis that that is the right thing to do. Now we need to make sure that people actually do it.
I mean, it's admitting a mistake and saying you're sorry, isn't it? It's the two things. It's not one, or it's both things. And I just wondered, you know, if clinicians did that as a matter of course, it would solve so many issues early on, wouldn't it? Because that's what people want to know, that actually you made a mistake, you're sorry, and they also want to know that it won't happen again to somebody else, I think is the other third thing. I'm just wondering whether we couldn't, with the Royal Colleges maybe, put out some very clear guidance to clinicians.
Yes, and I think particularly with the General Medical Council, for example, I think that's where they have a role. I think, again, we have to look at why it may be that clinicians wouldn't do that. And it may be, again, because they are fearful of what that might mean to either their reputation or to whether they could get struck off or whatever. And so I think it is important to look at the culture in which they're working. Again, it depends what the nature of the mistake is. And, you know, if this was reckless, then that's quite a different matter from just making a mistake.
Just a couple of quick points. The first one is not the high risk, not the low risk, but the belly of the distribution curve is where I think, just to say that we shouldn't really take our eye off the ball in that area, where there's the hospitals themselves look okay, but there's something in each of them that's an issue and that may not easily come to light because they're not yet on the high risk list. So I guess it's just a plea to keep track of those things where it's just one or two little blips of signal, not a lot of signals, but actually they could be fairly important to show about it. And just the other one, I mean, clearly the question of who does what after the regulators have found problems, in a sense we have to work with other regulatory bodies as you describe. But there is a layer between the boards and the regulators as to who might act, and one of that layer could include, for example, the academic health science networks, who are collectives or supposed to be collectives. I'm just thinking of David Fish's presentation, David and Robert. Some of them are some AHSNs are actually more developed than others, but it's not in our powers yet, but maybe there's some collective, I don't know, power we could think of or in future that might not put a sanction on, but encourage a network to help one ailing trust. It's just a...
Briefly, in terms of the middle group, I absolutely agree. I can't tell you how many different people over the months since Robert's report came out have said to me, you know, there's a little bit of mid-staffs here in my organisation. I'm sure others have heard the same. And so, no, we shouldn't take our eye off the ball there. Hopefully, a lot of them will be putting that right spontaneously before we even get to them. In terms of AHSNs and others, you know, the support, again, I think there's a mood change in the wake of KEO, where there's a recognition that some of these trusts need external support. Now, that external support might come from an academic health science network, it may come from further afield, it may come from mentoring and buddying arrangements, it may come from leadership academies, whatever. But some of them are going to struggle, but we need those health services, you know, because they are in far-flung parts of the country. They can't do without those. And I think that's not necessarily our responsibility, but we can, by having made a good diagnosis on the hospital, I think what treatment the hospital needs in terms of getting better should be more clear-cut. And so if it's leadership support, they can get that leadership support from wherever.
A couple of points. One is on what happens after the inspections, and there's a kind of a perception out there that you know, it could lead to, you know, you get put on special measures, and ultimately you could be you know, put into administration or closed. and even some people feeling there's a kind of vested political agenda there, which I have no idea. But I guess whether we need a sort of clearer message around sort of improvement and support, because, you know, and again, it's not just CQC, but, you know, if the outcome that we did a diagnosis and then the support that was offered wasn't appropriate or enough, and then the service or hospital or whatever eventually got shut down, or, you know, that I think, you know, from the public's point of view, may not be a good outcome, shall we say. I mean, maybe sometimes that is the right outcome, but at the moment it feels the emphasis is on sort of failure and shutting down rather than improving and supporting. And of course, I know the first 14 were where there probably were problems, so that may be part of the reason for that. So it's just the sort of if you like, messages, if the want of a better word. The other thing on the mental health side, very quickly, I think we really do have to say mental health and learning disability every time, because in some ways it's seen as a subset of mental health, but I don't think it is. I think it should be mental health and learning disability. And obviously I'm pleased to kind of have the reassurances that we're cracking on with it. But also to say that the majority of mental health and learning disability services are not in hospital, they're actually in the community. So, you know, when we're developing our surveillance and inspection model, we're going to have to develop it so that it covers where the majority of people are, as well as the hospitals.
Very happy always to refer to mental health and learning disability, and correct me when I don't, please. I think the point about the support for struggling trusts, I think one of the advantages of having looked at a whole group of struggling trusts together through the KEO process is that the recognition is there. Almost if they had been just dealt with one by one, maybe that wouldn't have been recognised, they'd have been thought of as isolated cases. The fact that the decision was made that 11 needed to go into special measures sort of, I think, has woken people up to the fact that this needs support, not just putting people into failure regimes.
Sorry, can I just clarify, what do we want our role to be? I mean, when you have this meeting on Friday with TDA and Monitor, what are you going to be arguing for that the CQC should do? And if we have new leadership teams going in as a result of special measures, I mean, does Mike have a role in appointing those people? Or can you just clarify what you think we ought to be arguing for?
This might be a three-way answer, so let's. This will be a challenge. I'll join up with you, won't it? The way the care bill anticipates this, and the way that we've been thinking and preparing for this in the conversations, is that our job in relation to hospitals is to assess the quality and safety of services. And that, in a sense, is the wave one that Mike is talking about. It is not our job, as conceived by the department, that we then go in and intervene in any way that can be construed as being improvement. Because when we go in again to check that improvement has taken place, we don't stray into that territory. I think the phrase that is often used of marking our own homework. So on healthcare, acute hospitals, there's quite a separation between the assessment of whether quality and safety is evident in services and how we assess and judge that from any action that's required. And that's why I refer to the care bill, because although it is called a failure regime in the way that people are using it, I think Mike is right to pull out this, that the intervention is really about improvement. The whole purpose of this is so that services don't fail. I think this is your point earlier, Robert, and certainly the surveillance methodology that we've been working on is so it doesn't fail. We can intervene at an early stage so it doesn't fail. So there is that quite strong distinction. You're doing the meeting on Friday, I think, are you, our team? So I'll let Paul say this. What the ambition of the meeting is. I think there is a legitimate issue with how, and David often makes this point, it's in our strategy of we are separate from the system. our judgments have got to be independent of the system, and this is, I think, this positioning on the side of patients. So our default has not been, gosh, it's tough in this hospital, or this clinical commissioning group is struggling for money. It's got to be, are people who use this service well served in terms of quality and safety? I don't think we can be devoid of the context within which that is operating. We can't be unthinking or unknowing about that. But our judgment is really about the impact of quality and safety. So I think that's what we are in effect negotiating. So our memorandums of understanding, the way we'll react, how do we share information within that context on surveillance? Once we've, Mike's point about, once we've done an assessment of the hospital, we'll come together on these quality summits. What is the nature of the conversation? Well, the nature of the conversation is, we have found this needs to be put right. Who is going to take responsibility for putting this right? We step back of, we have found this, and others step forward and say, who is going to put this right? We then withdraw from that, not in a callous way, but in a way that then allows that improvement activity to take place. We'll set the time frame over which that check takes. The judgment there will be about the degree of risks that people are presented with, and we'll have to go back in again to check. So I think these questions about when will we go in that were asked of Mike within that 12-month period, etc., are really calibrated depending on what the issues were in each of those 14 hospitals and the 16 that we're going to go in. But Paul, do you want to?
Only to say that the purpose of meetings like the ones on Friday is we all agree to the high-level principle. You know, the three-stage process that you've laid out, and they'll be in the care bill. But the assumption is that the devil's in the detail. So we're just trying to work through, what does it really mean at each of those stages, so that we don't get caught out. It's as simple as that. So far, my memory, there's an awful lot of goodwill to do this. We have use the sort of phrase of the commissioners again. It's overlapping, but legitimately different interests too. And we continue to hold the line that, as David says, we are there to expose, and we cannot get into the action plan ourselves, and we'll continue to hold that as an important principle.
Just to say, we clearly, the three of us are aligned on this, which is good news. And the only thing I would add is that in the precision of the diagnosis, we will help others to know what it is, the support that's required. And if I can pursue this analogy a little bit further, I am a physician by background. If I make a very good diagnosis, effectively the surgeon then knows what to do, but I then follow up and make sure that the surgeon has made somebody better.
Sorry, one other point of clarification, building on Camilla's point. I think as part of the care review, in one hospital at least, the review panel closed an operating theatre. Is that part of the CQC's powers when you undertake an inspection to be able to do that, or was there something specific to the KEO reviews?
Actually, my understanding is that what the KEO reviews could do was escalate it to CQC. But in practice, that's not really often needed. If you've got a good panel and a good panel chair who goes and then talks to the chief executive and says, your operating theatre is unsafe, are you prepared to take the risk on operating on anybody in that theatre in the next 24 hours? Actually, the chief executive who doesn't close it for themselves is taking a big risk. So I think that is what in fact happened, and my understanding at that one trust. So, and my experience with the cancer peer review program over the last decade is that we have quite frequently identified immediate risks. And we have always escalated them to the chief executive there and then, and to the best of my knowledge, those immediate risks have then been acted on right away.
I think this speaks to Michael and Camilla's point. One of the changes the Care Bill is introducing is our ability to take enforcement action is partly constrained by the fact that we've got to issue a warning notice in a number of situations before we can take enforcement action. The care bill is removing the need for a warning notice to be issued before enforcement action can be taken. So that makes, I think the point that Robert was making, it closes the gap within which we can delay taking action, so we can take action immediately. So there are some enforcement actions that we don't take. One is spot fines, in effect, where we've had that ability now since CQC was created, but I think no more than 4 of these have been taken during that time, and they've all been taken in adult social care, I think, rather than anywhere else. But I think, Michael, to your point about closing operating theatres, CQC has taken action to actually reduce the number of people in A&E by a variation, changing the registration conditions, basically, and we can do that within our powers. So when I presented earlier and I talked about strengthening registration, there's some of the legal powers that we've got which we can use to enforce. And again, historically, CQC have not really used those powers in that way. So there's work going on within the organisation, so we can actually develop the use of the powers we've got on registration, as well as the care bill giving us a more immediate way to intervene if we've got immediate concerns about risk.
Mike, thanks very much for that. Paul, surveillance model. If you hit your button.
Thank you. If I introduce agenda item 8 then. As we've noted elsewhere in the board meeting, we're furthest advanced on the acute surveillance. There's no doubt about that. The next seminal moment as far as acute surveillance goes will be the September list. I think, to your point earlier, Jennifer, how are we going to get around the problem that there will be a lot in the middle of the curve? That one of the ways that we can do that beyond just the ongoing running programme inspection is by publishing this list with all our surveillance indicators and making it very transparent to providers, to commissioners, to others in the system, where we have identified concerns, identified smoke alarms. And in the new sort of architecture of quality surveillance groups, I would expect these lists to start then being used as a questioning device. Are you doing whatever it is on the such and such an outlier, wherever it might be? And that's, of course, in addition to the fact that we haven't, our resource model won't imply that inspectors are always on inspections and not able to do anything else other than the provider they're currently looking at. So they will have capacity to also be sort of checking up as to whether these things are being followed up. But I introduced that as a kind of key example of how our surveillance can be used more broadly than just ourselves. The place I'd draw your attention to on the document is Table 1 on page 3, because that lays out where we think we can get to mirroring the acute process of when we'll have a date for the proposed first version of the indicators, and then when we'll be able to publish a full list. 2 points to note on that table. One is that the next sector, if you like, where we're aiming for is the mental health sector, closely followed by acute independent hospitals and learning disabilities. And the reasons for that is very much a risk-based judgment. It will take us longer. We are in the particular mental health. We've conducted a literature review, and we're now going through the exercise you'd expect to look at all the different indicators on the same model that we use for acute hospitals, with those Tier 1, Tier 2, Tier 3, with Tier 1 driving our direct surveillance, to put it that way. But I'd also draw your attention to the fact there are TBCs on that table, and that simply reflects that this is a very large programme, and it wouldn't be appropriate to say we've got it all under control, we know exactly when we'll do everything by. We are trying to bite this off in chunks and use a risk-based approach.
Is everyone happy with that schedule? Jennifer?
Just on my worry list, which is the out-of-hours primary medical services. And not to have a date for that, I think might be a bit worrying at this point, but I don't know if you have anything more to say.
No, I think that's right. I think that would be the next one we have to go to. We just need to make sure we've got the resource to do these things, but absolutely it's a worry.
Winterbourne View is also you.
I think there's a run of papers that I'm introducing, so apologies if you get bored of my voice. So this paper builds on a previous board paper and seeks to update the board on the 4 different reviews, both internal and external, which have followed the abuses that were exposed at Winterbourne View Hospital. They are the internal management review that we conducted, our overall look at learning disability services, the safeguarding adults review, the serious case review, and the Department of Health Transforming Care response to Winterbourne View. I think the summary here is that there have been a lot of actions that we have committed to undertake, many of which are rolling out or have been rolled out, some of which haven't. And the next step, therefore, there's the simplicity on we will continue to do what we've said we will do, but there is a step change that is needed, which is that we need to lay out what our approach to regulating learning disabilities hospitals like Winterbourne View really is, and that's in the same way that we've gone some distance to doing so through the June 17th consultation document on the acute trusts. We need to do that for this group of providers, just as frankly we need to do it for all the other sectors, and that's what will really change and give us, I think, sufficient confidence that we're regulating in appropriate ways, and then of course roll out the programme of inspections again, analogously to the way that Mike's described for the acute sector. A couple of points as to bring out within that then. Firstly, what action we're taking where there are not registered managers or registered managers haven't been in place for a significant period of time, which is paragraph 2.25 and 2.26. And to echo David's point, that's one where we do think we should use more fixed penalty notices. We are getting tougher on our enforcement. It's just not appropriate not to have a registered manager. That's a legal requirement. So for the bands 2 to 5 in that table, we're now taking enforcement action, including FPNs, and as necessary placing restrictions on registration requirements. The other part is that we've already committed to changing the registration requirements for new providers of learning disability services, and that started from this month. It is for new providers only, but it's explicitly there to ensure that there is a clearer understanding on behalf of the directors of or the leaders of those providers as to what their legal duties are and how they're going to fulfil them.
Sorry, it's just a point on page 5 at the top under 2.8 that some of the lessons about the oversight and supervision was to culminate in a public report to the board but hasn't yet been implemented. Could you say a little bit more about that, and is it going to come as envisaged?
Let me follow up on that, but I would absolutely, if we made a commitment, we absolutely should come to the board, yes.
Is there a date?
No, I'll follow up and find out.
So I'm pleased that we're taking the action where there aren't registered managers, but I just wondered what the response of these organisations has been, if any.
I don't have details on the individual ones, no, if I'm honest, Steve. I just wouldn't feel confident to say. I think you can imagine the range that we might expect, but no, I don't feel confident to say about individuals.
I mean, I think the motive for the action is to try and get registered managers in there. It's not to actually close them down.
Well, you can come back to us at the next board meeting on that, could you? Kay?
Yes, I mean, thanks for the update. and it seems that a lot of the issues will be sort of covered and addressed in our new approach, which is good. But what I'm sort of worried about is the next year or so, because what we have is a very vulnerable group of people, and we've got cuts to services that are starting to bite, and also the changes. And so, you know, I'm just thinking over this next year that I'd really like to know that we, you know, are keeping a firm focus on this group of people. You know, not just, yes, we're going to do things differently, but you've got a whole year or at least of quite a sort of challenging time. You know, and one thing, for example, this link between Mental Health Act commissioners and inspectors still doesn't seem to be working that well, at least across the board. You know, and I think it could be a sort of fairly pragmatic thing that we sort of, you know, make sure that they do actually speak to each other. They've got addresses or, you know, their email addresses or something. But just to sort of, you know, make sure in this kind of crucial time that we don't take our eye off the ball there, because they're so vulnerable, and it's, yeah.
Just to say, Kay, the link between Mental Health Act work and the rest of mental health and learning disabilities is very definitely on our radar, and how we can try and make that work better together. Certainly that's something that's been brought to my attention very quickly.
Yeah. Just on that, Mike, I mean, how soon are you going to be able to make an appointment to someone to lead our mental health sort of efforts and learning difficulty efforts?
Again, I haven't got a date on that yet. We're still trying to work out what the exact structure should be. But what we have got is a lot of people who are very willing to help us get going, and we've got good people both within the organisation and outside who are assisting us on that. And I think that will make it clearer what way we need to go in terms of having somebody leading on that.
Yeah, and also the sort of interim as well. You know, I know there's the changes, but it is the interim. You know, I mean, I'm you know, somebody I know recently, their son died in an assessment and treatment unit for people with learning disabilities. You know,
I completely take that, and I think we need to take that away and actually look at what the programme is that we have ongoing anyway through the regional directors, and then come back with what are we planning in this year. I've made a clear note on that.
We'll come back to it at every meeting from now on, Mike. I think you can be assured of that.
Thank you very much.
Steve?
So on Kay's point, and not intended to be an answer, because I'm not in a position to give you an answer, is two things. First of all, I think we as a board have to appreciate the enormous pressure on Mike and David and their teams to deliver this in very, very quick time. And some of that's a political agenda, and I think, you know, we've just got to make sure that we as a board make sure it's delivered appropriately as well as quickly as possible. But the second thing is, I think, and I picked this up yesterday when I was on an inspection, it's a mistake to think that our inspecting teams at the moment don't realise what's going on. And they described their inspection when we went to St Mary's as you know, the old system plus. And they are trying to change it. They are trying to introduce the new methods within the existing, and, you know, they have to say, well, we're still going to assess you whether you're compliant or non-compliant, but we will be looking at this, and we have got an expert with us, etc., etc. So I think there is movement, and I think you know, one of the advantages of the extensive consultation process we're going through is that people are picking this up, they're anticipating the changes, and they're welcoming them, and I think they're being incorporated as we go. So I think the picture isn't from black to white. There's a whole range to go through.
Sorry, just an addendum to that. I presume the same is also true for the surveillance system, that there is an existing surveillance system on which Paul and your team are developing, so that the TBC in some of those areas, back in the previous paper on Table 1, there is some ongoing surveillance. It's just not the developed surveillance that you want to see.
Yeah, that's right. And for example, the way that we get safeguarding alerts as one of the, there is surveillance, but I agree with Kay that we absolutely need something in the interim, and we will. And Steve is right about the way that things are progressing. but we are so sufficiently far from where we need to be on this sector that I'm equally mindful we mustn't give ourselves false confidence that by using better what we sort of already have is going to be enough. We need to do it as a stopgap, but we need to transform the way we regulate this sector in particular.
Thank you, Paul. Corporate performance. John, you
That's right. I've got some questions on and comments on this one, if that's all right.
Yeah.
The first point I wanted to make was that although there's been some improvement in the number of inspections where the remedial action has not been taken within less than a year. In other words, they are still non-compliant after more than a year being declared non-compliant. Although the number has gone down in most cases, not all, but most cases, it is still worryingly high. And I still am anxious that we are tolerating organisations that have been declared to be non-compliant and leaving them for a long time before subsequent enforcement action is taken. Something's getting better, but it's still some very long delays in putting things right. The second point I wanted to mention was I think that the inclusion of the feedback from organisations that have been inspected is actually really, really helpful. This is the first time I've certainly seen this. I don't know if it's been done before. And the knowledge that was clear a few years ago that we were sending in inspectors to inspect organisations who didn't know very much about what was going on in that sector is still there in a worryingly high proportion of cases. Some cases up to 20% of those inspections are conducted by people who give the impression of not being clear about what it is that they're inspecting. And I hope that that can be addressed, because I think that is a long-standing criticism which really we ought to have eliminated by now. And my third question is about the complaints. Building on the discussion we've had this morning, I think it's probably good news that we are getting more complaints, because we had a significantly low level of complaints historically. So I think it's good that people feel able and know how and are able to make complaints. And I don't particularly now want to go into a long, detailed explanation of exactly who made what complaints about what. But what I would like, either now or at some point in the future, is to be clear how these complaints are dealt with. 60 of the complaints were about members of staff. And I'd like to be reassured that those are being considered at an appropriate level in the organisation, that action is, that there are no, if there are patterns about where those complaints are, that is being picked up, action is being taken, and that if there are lessons that we need to learn or need to be reported to the board, that process is going to take place. Thank you, David.
Paul, do you want to respond to that?
Well, I think we should come back to you on the final point on complaints and whether that sort of 39% of the total number that's about the conduct of staff. Overall, on the report, I mean, I think the point to get across is that particularly on the activity side of the programme, we are broadly on track, and that's on track against a 49-week programme, so it builds in 3 weeks at the end as well. So I think there's a level of assurance that we can give that our activity programme is doing well. I think John's it's right, and it's good that we have the quality measures in terms of people telling us what they thought of our inspections. We do need to follow up on the point you raise, that not all our inspections are seen as credible. I think that's a fundamental part of the generalist to specialist switch, which we need to roll out. The piece that I know we've discussed in the executive team and will continue to get better on is the way that we assure ourselves and yourselves of the quality of our regulation by sector, not just that we have been in and seen stuff, and that is part of our transformation programme. Just a couple of other areas I think we should flag. The transformation programme that Hilary can comment on is overall rated amber red with 4 particularly high risks, and although that does reflect the nature of the programme, that it's very large, it's taking part, it's high profile and it's at an early stage, nonetheless I want to highlight that we do see the need to mitigate a whole series of important risks there. We have deteriorating performance on the compliance reports within 25 days, which is something that we're therefore clamping down on, but to highlight that, those would be the areas I'd highlight as remaining concerns, but it's an overall good context.
So just on this point about complaints, we've previously had, I'm reaching for the date now and I can't quite put my hands on it, a report which did analyse the nature of complaints, and I think our commitment was that there should be a regular report to the board which did exactly that point, John. I think what this report is flagging up is that following the publication of the Grant Thornton report, we had a spike in the number of complaints coming in. We've had a spike of FOI requests and a spike of subject access requests that have been considerable, and I think that's the increase that is showing through the figures that you've got here. But the basic point about doing that analysis of what do these tell us rather than how many have we had and what were they about is something that we'll pursue. So we'll do that. Just say one more thing. I'm not sure at what point we'll get to specialist on our inspections before April 14, if I'm being brutally honest. So I know these questions will keep coming, but we're on a trajectory to begin to change the structure, and the original timetables we've been setting out do not see us complete that migration to a completely revised structure until the autumn of 2014. Now, one of the questions I've been asking is, given we've made good progress on bringing in Mike and Andrea and the other appointment, is there a sense in trying to bring forward some of those dates? Or the change management theories, make up your mind, then do it and do it quickly. The challenge we've got is we've got 44,000 inspections to deliver this year, to a standard, to a quality that you will ask us about, and with the enforcement action that needs to be in place, which is the other challenge. And therefore, what I feel we're constantly balancing is the speed at which we make the migration to the future state, without prejudicing the invention of the new methodologies and tools that we need to use, and delivering our current responsibilities. So the original timetable we've been looking at sees a transition to the fully changed structure in October 14, but not moving the bulk of people into new jobs until beginning in April 14. So I don't think those absolute numbers, the 20% you quoted, John, on our current plans, unless we bring them forward, will actually change substantially till that point in time. Thereafter, it will change, but within that, I expect that 20% to move as people specialise, where people opt to do health inspections, care inspections, or effectively primary medical services inspections as we move towards April. And that transition is pretty much taking place now, but the distribution of our staff is uneven, quite frankly. We do intend, it's just being finalised after the gremlins have been chased out of it, a skills audit which for the first time will give us a full audit of the skills of our staff. I'm sad to say that we don't have that. I honestly cannot tell you, bar when I go and speak to inspectors, put your hand in the air if you're a nurse, put your hand in the air if you're a social worker, put your hand in the air if you're something else. And I think that's broadly working on. 60 to 70% are from a care or health background, and there's 30% or so who are from a much more generic background. Now, some of that might be non-clinical management in the NHS. It could be a background of performance management in a local government setting, or it could be they're a police officer. could be teachers. So we actually need to sort all of that out. The fact is we've got a duty to every single one of those members of staff because they're our employees. They were recruited in good faith on an understanding that we've got a generic model of inspection. So part of what we need to do is actually make that transition. That's why the academy is important. So I don't mean to go on about that, but they're the judgments. And as I say, we're constantly reviewing, should we drag some of this forward in relation to how we should move forward. At the minute, it's just staying where it is until we've got more. Your question to Mike about when will the head of mental health come in? Well, I think we'll put the advert out after the holiday period. There's no point in doing it now. So that's September. That means body not in until December. So I think we're in. There is a rhythm, to use a phrase that Paul used earlier, of making a decision about what people you need and then recruiting them. And that rhythm is probably about a 5 or 6 months from beginning of the decision to the body of the person appearing and beginning to come in, which really pushes us into. I can't see some of these changes taking place until 14.
David, if I may, one of the factors may be, it's difficult to know without understanding the data more effectively, but one of the issues may be that as you slice and dice your workforce to make it more specialised, you take account of the geographical distribution of that workforce across the whole country, that actually you have to have more than the theoretical number of people that you need. Otherwise, because you don't have them in the right places to be able to do the right inspections at the right time. Now that may well have implications for the recruitment of your bank inspectors, which has to be sufficiently early in the year to give you that flexibility later in the year. That's, I think, the point that you might want to consider in terms of the recruitment and the flow through of the raw resource into the allocation that you're making.
Quite so. So on Monday of this week, Paul brought some what I thought was quite outstanding work of profiling and modelling the number of inspections we need and the number of staff we need to do that. Suffice to say that was done by an analyst, not by a strategic HR person, that then converts that into what is the future workforce in 13, 14, 14, 15, 15, 16. And then when we get to our steady state, what the steady state numbers are. The only way to do this is tell it straight. We do not have a strategic HR capacity. We need to recruit that strategic HR capacity. Then we're looking at what's the skill mix and the numbers we need as we go through, well, I would argue, the next 5 years as we build all these models up so we can actually answer these questions. What we've got is some fantastic work which we've done on hospitals, but we need to do that modelling for adult social care and primary medical services before we can say this is the optimum number of people we need. And if we're going to have a further conversation with the Department of Health about the resources we need to do the job, the capacity we need to do the job as distinct from the capability we need to do the job, then we need to have those numbers by October. So this is a bit of a burning platform, because the last conversation we're going to have with the department before we go into the election, and therefore in this government's term, is this autumn. Whatever the 15-16 spending review says, that will be another government that takes that forward. And therefore we are burning platform. So I've asked Paul to actually do as much work as we can to repeat what we've done on the NHS, where, as we've heard during today, we've got more data on the NHS than we have in social care and primary medical services, because we need to do that strategic HR work about capacity and capability. Question: do we have enough money to employ the people we need to do the job? Have we got the right skill mix we need to do the job? On inspection teams, what will our employed workforce be as distinct from what money do we need to buy the skill from people that are doctors and nurses in hospitals that we need to be part of the teams, etc. And so that's Summer's job for Paul.
Clearly, we need to make sure we've got the resources to do the job, and it sounds as if the predecessor organisation did not necessarily make that point sufficiently. But also, is it our role as a board to make sure that we spend that money effectively? I mean, do we have a finance committee of the board? And if not, can we have some sort of consolidated P&L? Because I don't know about everybody else, I can't actually read from these two finance documents. They do not assure me that I can't see our cash flow, and I can't be sure that we're within budget. You know what I mean? So I don't know in what form it would be most helpful to have that information, or whether we have a finance committee which is responsible for looking at that, but it's surely part of our role as a board, isn't it?
We have an audit committee of the board. John, do you want to explain what you do on that?
How much time have you got? Yes. We have a combined audit and risk committee, and the audit committee deals with the sorts of issues that we're talking about. We don't have a cash flow because we're a public body, so we're bankrolled by the Treasury basically. But the issues about efficiency and effectiveness are very much in our domain, and that's something I feel very strongly about, and I'm happy to talk to you outside the meeting. We also have obligations to give the board assurance about whether the risk, both corporate and regulatory risk, is being properly managed. We don't do it. That's the job of the executive, and the risk. The judgment about what are high and low risks is for the board, not for us. But what we do is then say whether those risks are being analysed, assessed, mitigated properly, and give the board assurance, because that's quite a detailed process of going through mitigation plans and so on. So that very quickly is what we do, but I'm happy to pursue it outside.
Sorry, just one point. So I don't know if everybody else already knows this. I mean, is there a threshold of expenditure whichever needs to come to your committee or the board? I mean, can David spend an unlimited amount of money, or is there a point at which somebody has to?
We don't do executive action, so we don't authorise particular levels of spending. That's for the executive and for the scheme of delegation, which David is responsible for. So we don't do that side of it. You have to direct that question to them.
So, having been so directed, this is a performance report. It's not the finance report. You do get a finance report, Camilla, which will go into detail, and I would hope that would satisfy the questions you've got. And the new Director of Corporate Services will take responsibility for that, but Francesca Annis is the head of finance. She's a qualified accountant, and I think she'll present the information appropriately. This is a new form of presentation. I think this is John's reflection, and we'll work at getting the finance report right. You do have a responsibility to challenge on value for money and effective spend. That's absolutely right. As accounting officer, I've got a personal responsibility back to Parliament for that as well. So there's a kind of double lock on this one, which feels uncomfortable at times. I think our finances are relatively straightforward. To be honest, I've been responsible for budgets as a Director of Social Services, which have just been a nightmare to manage. Unlimited demand against a fixed amount of money is really challenging. We're pretty steady on this. And there's a later report at item 11. Well, there's a later report anyway, which I'm asking your permission, because as I've got a delegated limit up to 500,000. Thereafter, above 500,000, I need to do that in consultation with the board. So there's a report later for the renewal of an IT contract, which is total value over the period 1.4 million. So I can't make that decision by myself. So there's a report to ask you to make that.
So the answer is £500,000 to the Camilla's last. Anything more than £500,000 has to come here. Yeah.
Yeah. I need to check. I can't carry those figures around in my head. So if somebody gives me something, I said, what was the scheme of delegations? And I dig it out. I normally have to check on the scheme of delegations, but there's a Treasury-driven, Cabinet Office regulated scheme of delegations for all arm's length bodies and people like me, and it's pretty well laid out.
Thanks very much. So I think this report, if my memory serves me right, this report looks very, very different to reports we've had before. And so I kind of want to start by saying thank you, because it feels like it's got a whole lot more really useful information in it, which we might have wanted to have for a long time. And so thanks to you and the team, Paul. And so one reflection, you ask us to reflect on presentation, and what was really interesting for me was, and this is in a way this is an acid test of these kind of reports. What was really interesting was what you said by way of introduction, Paul, about which issues you thought were worth remarking on. And that's what I think we're missing in this report. So we've got a long textual introduction which really kind of repeats what's in the slides. And actually what we need is, and these are the 5 things that we think as the executive are issues which need to be addressed, and you need to assure yourself that we have addressed. And in a sense, the very fact that you've surfaced those 5 and not 20 is indication that you're in the right, your heads are in the right place, and that for me is part of the test. And it sounds like they are in the right place, because they're the things that pop out of this report. But does include actually perhaps additionally this question about age non-compliance, which you're quite right is dramatically improved, but perhaps not yet in the place we want it to be. So there's something about direction of travel, but not yet there. So. So that's all good, I think, for me, having seen a variety of other presentations of this, definitely going in the right direction. I wanted to have one word about the strategic risks, and this is covered in 2 places. So on page 11 and then in the strategic risk register. And I particularly wanted to focus on the one around public confidence. So there's a suggestion that it needed to be reframed, not about whether or not our reputation would be damaged, but how we could rebuild our reputation. Actually, in the table, it talks about levels of public confidence is really what this is about. And I mean, I think the assumption is, and I'm sure it's a correct assumption, that levels of public confidence have reduced, and I mean, our task is to increase them, but actually what matters to us is how high they are and how high they should be. That's the test here. And so that makes me want to ask the question about, do we know? So what do we know about public confidence in the CQC? How are we going to measure this? Because it seems to me that, so you've got some measures in here around the consultation responses, and the impact on what I think are probably more likely to be stakeholders of the work that we do over the course of the next period. But actually, if we're concerned about public confidence, levels of public confidence per se, I think we need to do that work. And now is a very good time to get the benchmark, because we suspect, I think reasonably, that it might be as low as it could be. So it will give us a good test for how much we can improve it over the next period of time.
So I think our first challenge is to know who even knows about us. If I remember rightly, the figure, it's something like 4% unprompted recognition.
I bet it's more now.
Yeah, thanks. And possibly 19% prompted, but yeah, slightly going up. So yeah, absolutely yes to getting the baseline and then measuring it. That's what we need to do. But I think even then we need to just distinguish between people who know about us and their view versus people who don't know about us, and we need to take a view about whether we're comfortable, whether it's the best possible regulation, one that nobody knows about but does brilliantly, or whether we need to be known as well. But the basic point about having a baseline for the data is right. Yeah, thank you.
But this may be pedantic, but actually I think that what we're talking about is building public confidence. I don't think it was there to be lost. I really don't. I mean, maybe amongst a few people, but and it's a different task, because building it is actually a different set of social relationships. Then it's not just being good; it's actually people knowing what you're doing, and I think it's a different thing, and I think we've got to build public confidence.
Sorry, I'm going to be even more pedantic probably, but I mean, isn't what's important is that we do a good job? Isn't public confidence going to be correlated with whether we do a good job? I mean, I'm not sure we should be sort of obsessed with, I mean, we want to be very careful we do not look obsessed with PR. I mean, there's a case for saying that we want people to be able to access, your point about the organogram, we want people to have a better understanding of how they can complain. But I would have thought that's more important to us, isn't it, than public confidence? Because public confidence is just going to rise if we manage to get everything else right, isn't it?
Can I just come back before Paul does? I mean, I think you're absolutely right. We shouldn't be obsessed with what levels of knowledge there are amongst the general population. Actually, the reality is that the better a job we're doing, the less people need to know about us. That's absolutely true. But there is something potentially quite damaging, and Paul's also right that we didn't have a reputation amongst the public before, but we probably do now, and the reputation, I suspect, the reputation we have now is not a very good one, and that has a really severe impact, actually, not on us, but on people's confidence in their approach to health and social care services. So it has a much wider concern for me. So I've always said in other regulators, actually, our job is not to make sure that we're a household name. Our job is to make sure we're not a household name. That means we're doing a good job. But I think in this case, the fact that our reputation may not be very high is probably damaging and worrying for consumers and users of health and social care. And I think it's important that we monitor how the good job we're doing, which I hope we will be going forward, contributes to a greater level of confidence in the way that people approach services. So it's a wider public interest test in a way, rather than a measure of our success for me.
Sorry, you're gonna hate me. I mean, I just am really worried that when you make, we're drowning in paperwork already here, right? When you make, it's very important to get this list right, simply because as soon as we put public confidence in a box, at some point, poor old Paul is going to have to be asked to create, seminars, I just kind of, do you know what I mean? I'm just concerned that it's going to, I totally take your point, and I think it is really important that we have public confidence, but I'm not sure whether we should have it as a sort of output that is going to then lead to a frenzy of activity. Do you know what I'm sorry, I don't want to overdo it, but...
Let me give you an extreme indicator. Ofsted sets the price of houses. That seems to me has an impact on the public. That's because people go there and they trust what it says. And they trust so much what it says that they buy houses near schools to make that so. Now that may be an extreme, but it means that it matters to the public, and they trust what it says. I'd like people to trust what we say and to be the go-to place about adult social care and hospitals.
Was Paul's refinement is having confidence in the judgments that we make, and that's where we need to have public confidence, so they actually trust our judgments, that they're reliable, robust, fair, and the rest of it, and that's where we need the public confidence. Otherwise, what's the role of the regulator?
I had a slightly different point, I think. This is the first time I've seen the risk register, so apologies if this has been considered and I'm really making a non-point. But I would have thought the biggest risk the CQC faces, and it would, as it happens, affect public confidence, is if the surveillance system failed to pick up hospitals where there was a risk to patient safety. I would have thought that is the number one risk on the risk register. And probably the second risk is that we do an inspection, and obviously I'm highly reassured by what Mike has said about the nature of the inspections, but that an inspection fails also to capture problems in the hospital. I would have thought that those are by far the two most important risks for the risk register, yet they're actually not mentioned, although you could argue that some of these more generic risks could cover them. But I think those, my own view, for what it's worth, is we should specifically have those as risks, because they are the biggest risks, and they, as it happens, also would risk public confidence, because we can't have public confidence unless our surveillance system is effective and our inspections are effective. So that's a point about the risk register. The second point is I've never seen a performance report before, so I don't know the extent to which this is an improvement. I'm sure it is an improvement. I have to say I found it almost unreadable. I didn't really understand what it was trying to do. And although I could sort of see that every section had feedback on the quality of inspections by the organisations that have been inspected, I presume that's what the left-hand side of these charts were. Non-compliance really puzzled me, because what was the about what were these organisations not compliant? So there was sort of data on proportions of non-compliance, but nothing about what the compliance was about. And, you know, were they non-compliant about something that's very serious? Were they non-compliant to the results of an inspection? I just didn't understand it. So I don't want to criticise the performance report. As I say, I haven't seen the previous versions, but I did find this difficult to understand and difficult to know quite, you know, how to read it and what to take from it. So, as I say, unfortunately, two sort of negative points in a way, although I think the RICS register is very easy to, if colleagues agree, to change and to modify. The performance report, I think, needs a bit more thought about what it should be about. I mean, for example, you know, there were 96 NHS inspections during Q1. What did they find? I mean, there's nothing in here which says what the results of the inspections were. So I think there is scope to improve the, to further improve the performance report.
Paul,
I'm adopting Robert's point that non-executives should be challenging.
Well, I mean, on the first point about the two risks that you mentioned are the two key risks. Completely agree. I don't think anyone would dispute that. And actually, if we're not right on both those things, there'll be no public confidence in this at all. And what is the point of us, actually, if we don't get those two things right? So they should be right at the top of the risk register. They are absolutely critical. And when we publish our surveillance list at the end of September, if that is not right, then that will reflect very heavily on us. And equally, when Mike does his 18 inspections, if we miss something in those inspections, then again that will reflect absolutely on us. So they are absolutely critical.
I absolutely agree, and those are the things that are going to be keeping me awake at night, missing things. I think we need to distinguish between things we've missed because they have been covered up, which may occur, things that were not brought to our attention, and so we need to be very proactive in asking trusts to give us all the information they have, and things that we have missed ourselves. Although I suspect at some point we will miss things, and I think that is in the nature of the business, and I think we just need to recognise that, but we need to do everything we possibly can to minimise that.
But I think, I mean, picking up Paul's point about Ofsted, I mean, Ofsted have been through bumpy times, but they are huge, their judgments are hugely respected, actually. And they may get it wrong on some hospitals, but Ofsted's, you know, when they say a school is outstanding, you know, people think that is a serious judgment about that school, and equally when it's in special measures.
And I'm sure we should aim to get to that same position, but just to re-emphasise what we've all said before, which is that hospitals are rather more complex organisations than schools, and it's Jennifer's point as well that, you know, we may miss a particular department and something there may be happening, and that is perhaps my greatest concern.
On the performance report, I'm glad you mentioned that. I tend to rather my glaze over when I look at performance reports, and that is a bad reflection on myself. Paul, we need to spend a bit more time on this. And maybe, Michael, you could help us with that as well, to some extent, in how we set out this performance report. Jennifer?
I'd be delighted to do that.
Thank you. Jennifer?
So sorry, it's just what I was sort of droning on about earlier. There's something about what's in the performance report which may necessarily be high level, And then there's something which could be deeper about what is on the worry list. Because, for example, there's quite a lot here about the number of enforcements and enforcement actions and also aged non-compliance. But in a sense, that may be something that one would want to abstract and have more information on in a separate worry report.
I will say that the worry list, based on Paul's surveillance model, is 100 times better than what we had before. I mean, we didn't know what we were worrying about until quite recently. At least, you know, we've got a basis for our worries now. I think you'd agree with that, Anna, wouldn't you? I mean, we have come a hell. I mean, you don't know because you didn't see what was there before, but it's a heck of a lot better, even though it's far from perfect. Okay.
I've got a couple of points. One on the performance report. I think, to be honest, we're partly looking at a sort of legacy issue, you know, because we're still delivering largely under the old. Well, it's old, it's current. So, you know, I guess it might be better to sort of focus on what we want to see as our performance, our key performance indicators, whatever, for the future. Because I don't think this has been sort of fiddled with so many times, and I don't, you know, so I think it would be better for us to think ahead about the kind of things that we want to look at, you know, based on our new strategy and our new approach. Yeah. Okay. I mean, the other thing I wanted to say also, and there's a little bit of deja vu in the sense that we are delivering a major transformation and delivering business as usual, because it was quite similar to that when we started. I mean, actually, it was more pressured. So I guess what I wanted to say is that actually we are delivering on our commitments that we've made, and I think we need to kind of acknowledge that we're doing that under quite sort of difficult circumstances, and that's quite an achievement, actually, you know. And it may be that we've, you know, you might say, well, we don't know too much about the quality of our inspections. Well, we know something about them, you know, but we are, you know, we have delivered. We are performing well, actually. Plus, we're delivering this huge transformation, which, you know, we must not underestimate, and hopefully we'll have a conversation around our sort of capacity and capability around that, because, you know, as a board, it's sort of why didn't you do that yesterday, or why aren't you going to do it until 2014? And you think, well, that's ages away, you know, and maybe there is scope to move forward. But I think, you know, you should also push back on us and say, which you did, in fact, David, I think, to say, look, you can do it too quickly. You know, we it might feel uncomfortable to us, actually, but if it's not possible, you know, it's more risky to try and do it quickly, too quickly, shall I say, than you know, taking our time so that we actually get it right. But it's, I mean, I appreciate it's a fine balance. Okay.
Well, I've been doing this job 12 months last week, I think, and I think this is the 5th iteration of the performance report to this board. So, what is it? Perfection is the enemy of the good. So, just to connect Michael's offer, or your corralling Michael to offer, and Kay's point is, I think there is merit in saying, on the model that Mike's designing, what's a performance report we need for that? Because we are, by definition, going to run this out by April next year. So there is a sense, I'd ask the board just to consider whether this is good enough to get us through the remainder of this calendar year, so that what we spend our time and effort on is inventing the future rather than perfecting something that we know we're going to get rid of. My preference would be to do that. If I could ask you to do that. I think on this issue, Paul, I think you're absolutely right, and it's a point powerfully made and not lost. And Michael, you were right about whether we've got the right priorities in relation to the report. There is an operational risk register, which I think reaches for those exactly those points, to be honest. So again, it comes to how do we report this in the appropriate way. Jennifer, I think your point is right about whether there's a high level and then a more detailed one, which is not a million miles away from what you were saying. So, but I think the real point I'd want to land on the confidence point is how it impacts on staff. So on the weekend that we did the Care Homes Open Day was the day that we published Grant Thornton. So we'd got over 250 inspectors going into care homes on the Friday after we published the Grant Thornton report. And they walked right into the having to defend CQC. Interestingly, the stories that have come back to me are some people felt under pressure and unable to do that, but the vast majority was of support for what we'd been saying. I think this speaks to the point that you were making earlier, Robert. Actually, if you've got it wrong, admit you've got it wrong and then say you're going to put it right. And I think what people connected to and what staff felt able to identify to in the main was that narrative. But the confidence point is our staff need to be confident when they're going out to be challenged to do the job that we're asking them to do. So I think that's one of the way it washes back, and that's not really been part of the narrative that we need to continue. On this issue about work loads and pace, etc., I'm probably as impatient as anybody around the table about getting this done, but with the best will in the world, we're trying to move 2,000 people, 44,000 different sets of interactions, and a system which is less than 5 months old. And the thing I've learned over the years about change is if you don't do it properly, it won't be sustainable, and you take out some key ingredients and the thing will just fall over. And therefore, I think building sustainable change is the balance that we're trying to make. So when I think it is my job, David, with the senior management team and with you at a board, to have this conversation here about what the balance is between pace and sustainability of what we do, and that will constantly be needed to be crafted and tested. I don't think there's a you're right or you're wrong on that. I think it's a continual dialogue that we need to get in place. And that's what we're committed to do.
I think that we've got the 18 new inspections starting from September. Given from where we were, looking back, a few months ago, that's not bad. The fact that we've got the surveillance model in such a state that we feel we can publish its results by the end of September. I think there is a lot of progress going on. I think when you're moving from the generic model to this expert model, it means every single employee who works for CQC virtually has got a complete change in their job. So it isn't just going to happen overnight. But I think by March, if we roll the clock forward to March of next year, the organisation will have the 3 chief inspectors will all be imposed. The whole organisation will have shifted from a generic regional structure to a sort of a functional structure. That is a pretty quick work, I think. So I think the next 6 months, and we're nearly there, but we're not quite there yet, I think. Jennifer, then Paul.
So sorry, just a very quick point, not for a long discussion necessarily, but on the risk register, I think there's also risk that you must have discussed before, which is about respect of NHS staff. So it's not just public confidence, it's the respect of the staff who are being inspected. I think that's quite critical because they are 1.2 million, and care staff as well. They are also the public, and so extremely important to be mindful of that.
I think it's public, professional and political. I think there's all 3 components that we need, and the respect of our staff as well, I think.
On the way that we cut the risks, to Michael's point, as David picked up, we do have a separate risk register that tries to get into some of the more crunchy issues rather than that sort of strategic level. But to the question, is it hospital surveillance and hospital inspection? They are definitely 2 of the top risks. But I need to keep reminding all my teams, it is genuinely all our sectors as opposed to just acute hospitals. And on Camilla's point about public confidence, because I oversee the communications team as well, they are asking exactly this question because it's a real tension that they feel. They had some messages, I think, under sort of previous regime as to what their role may or may not have been. And what I'm trying to say to them, I think we're all saying as an executive team, is if we are serious about putting the public at the centre of everything we do, it is legitimate to know what the public think of us. So we should, to Anna's point, I think that is right, that we should measure it. But what matters to me is the ordering. And so if we ever did it, and I wasn't here to say it, but if we ever did it where we started from the perspective of what will look good and then tried to tell people about it, that is completely wrong. What I want us to do is we do the right things, but it is completely legitimate to professionally explain that we have done them. And that, I think, so when we had Mike's arrival, the right thing to do was to prepare for that and to get the list of 18 trusts we were going to go into in wave 1. But I was pleased with the team because then they professionally supported Mike to get that message across. And I think that's where we need to just keep landing. This is not about managing a reputation at all. It's about doing the right things and being professional about explaining that. So our thematic activity programme, this is a small number of pieces of cross-cutting work that we do every year. We have a variety of thematics. So, for example, we have thematic inspections, but we also have thematic probes and thematic reviews. So the general term is anything which is cutting across and give us an opportunity to rise above what we see at an individual provider level. And let me just pick out 3 things from this paper then. Though there are 2 new thematic inspections that we would ask you to agree for this year, which is the dementia work and the transition of children with complex health needs from children's to adult services. There's then 1 thematic probe, which sounds a bit like something that Mike would have done in his clinical practice, but it's in response in part to Camilla's review and looking at healthcare assistance in the training, and 2 new proposals which we're looking at for thematic inspections. One is the emergency mental health care, and the other is the end-of-life care. In both cases, we have given some public commitments, but wanted to bring these to the board for your approval.
Any questions for Paul on those thematic probes, reviews? Kay?
The one for transition of children with complex needs to adult services, and I just wondered why we're excluding young people with mental health and learning disability issues, because it's, I don't know, if thinking about sort of parity of esteem. I mean, I'm reluctant to say include it because it would immediately kind of probably increase the scope and make it not viable, but it's sort of a glaring admission. Yeah.
Okay, let me go away and check it. My understanding when I'd read it was that when it was young people who received care for 3 or more multidisciplinary health professions, sort of long-term or chronic conditions, I had assumed that included mental health. If it doesn't, if you know otherwise, or I can certainly go away and check it. So it's on 2.1.1 on page 5. But I can certainly double check that does include mental health.
Would you check that and get back to Kay on that?
Yes,
will you?
absolutely.
Okay, thanks. Paul?
I think potentially these are very important, especially something around end-of-life care, because they are cutting across the institutions that we're holding responsible for at the moment. I mean, what's going on out there in the health and social care service is an attempt to construct a completely new business model of care around integrated care, which cuts across the institutions that we are, in our current model, driving responsibility into. And that's very, very important that those institutions are responsible. But actually, by this time next year, a percentage of care will be delivered across those institutions with responsibility above them and in some way separate from them. And we need to prepare for the next revolution, I'm afraid, David, in the way in which we do our work, because at some stage in 4 or 5 years' time, we'll be looking at integrated care organisations, which are across and integrated care themes, as our main business, and not looking into institutions. So the more practice we get at that with these thematic reviews, it will be very important to be able to do that and be able to judge how to do that.
Thanks, Paul. So when I look in our sort of armoury, or whatever sort of non-military analogy it is, as to how we can look at integrated care, this is the best we've got at the moment, but I don't think it's enough. So one of the many things we need to do, but on the more externally facing, how is the regulatory world changing and how do we adapt to that? I think we will need to develop our strategy, our policy, on just how we look right across a patient pathway, as a matter of course, not as a thematic that we layer on top of other stuff that we do.
Yeah, I just to follow on from what Paul was saying, I mean, I was, as you know, quite concerned when we identified the kind of general inspector roles, the chief inspector roles, not because I didn't think that was a good idea, but because I was concerned that actually we'd lose integration as a consequence, and more importantly, we'd lose people in the round with all their experience. They'd be kind of cut into these portions. So I also think this is really important. It may be the only thing available, but we need to make the most of it. And what struck me when I looked at this report was that was two things. First of all, I suppose one, the importance of starting with that user experience to define the work, which I think is in here, but I just think it's really critical that before we kind of scope what we do, that we start with that experience as it's described by people who are in this position, whatever position it is we're looking at, and the second, that actually part of the ambition for this piece of work is not just to learn some lessons about what good looks like in respect of these things, but actually to think about what we can learn about what some of the indicators might be for good integrated care across these various different pathways or just different sets of experience, because those are things that we could then build into the other, if this is across, we could then build that back into the vertical work when we look at a hospital, for instance, to see whether or not they're set up in a way which is going to create the conditions in which there is good integrated care or not. So just kind of the two have to play into each other, I think.
I think both are really powerful points, and this is one way we can do this using our current methodologies. We had a conversation earlier about investigations. They can also do that, so we could look at dementia care in West Yorkshire and maternity care in East London to actually just pull out that point. Mike's job description, Andrea's, and whoever wins the interview process tomorrow, all three of those job descriptions have integration built into them. And we've asked the GP to take a lead on integration, to pick up on exactly, we're trying to hit a moving target here, it's going to move quite considerably. And certainly my vision for this is I think we'll look at some things where we'll draw staff from hospitals, social care and general practice inspection teams, put them together in an inspection team to look critically at something, led by one of the chief inspectors on behalf of the other two, or led by all three of them. So any way that we chose to organise, there will be an artefact that we'd have to deal with, which is how you look across at the reality of somebody's experience. So if we'd have gone Chief Inspector of Older People Services, Chief Inspector of Children, you'd still have to cut this then by institution. You'd have to do it in some way, because there'd still be a worry about, if I have my hip replaced in Blackburn Hospital, will I get an infection? So we chose to structure in a particular way, so it's absolutely essential then that our tools and methodologies and ways of operating allow us to do exactly that. So I think the 14-15 inspection programme will have thematic inspections in, but they'll also should have some investigations in where we're looking right across the patient, if I can use that, patient pathway, care career, whatever language we end up settling on, so we can actually take a much more citizen-inspired view of what the reality is. If I live in Blackburn, what is it like to receive health, care and primary care services in this town? Are my needs met? Does this feel something that's coherent to me? And that's the prize I think we need to reach for. But it'd be wrong to pretend we're there. I think you're challenging.
So I was going to ask a bit more about the style and nature of these inspections. and whether we were changing them. So I was pleased to hear Paul confirming that we've got to do more work in that area. So I think what I would really like to see is you know, we've got a whole raft of work going on about new inspections of hospitals and all the other institutions that we inspect. Are we going to, and I think Paul has confirmed this, we're going to review how we do this. And I think, not wishing to add to anyone's workload at the moment, I think that's quite important that we do that urgently, because I think the themed inspections are very important and a very powerful tool. And obviously we're increasingly being driven down in themed inspections by requests from government and other external factors. So we've got to get these up to scratch pretty quickly. So I'd just like to know what the planning for that is.
Yeah, so on the basis that pretty much everything else about our model is up for grabs, it would seem strange to sort of say, to have anything else and an expectation that it can and should change. So yesterday I appointed a new director of intelligence who would lead on that, Emma Rourke, who's from within the organisation and currently actually leads on the themed inspection. So as she sort of develops her programme, I'd be quite surprised if it didn't have this element, because I know it's one that's close to her heart.
I meant to say this to you, Paul, when I got the board papers. I haven't seen any of the results of the HCA thing that relates to my review, so I'd love to see them.
I don't think we've put the report out, the results out, but if there's anything that I'm sure there is things we can share. I think we had over 1,000 surveys carried out. I'm very happy to share stuff before
I mean, I think
published.
you know I was quite nervous about the first version of the probe. That was before your time, I think. So, quite interested to see how it's improved.
Okay.
Sorry, just quick ones. This thematic activity, it may be a good idea to think about focusing some of it on areas that the surveillance system is going to be developed later on. So primary care, for example, if we can't develop the system later, then actually a thematic review could be something that could help in there. And the only other thing about integrated care is that you might think of looking at the Pioneer programme, because that could be a really good advanced set of integrated care systems to.
Right, Paul, I think it's you again. Strategic partnership plan.
Thank you. So it's item 12. So again, this is something we've touched on, I think, earlier in the board meeting about the fact that we need to balance off the fact that we're an independent authoritative voice in the system. That does not mean we have distance or pure distance from all our national partners. So by way of introduction to this paper, we focus on, at a national level, 6 other arm's length bodies or regulators, the list of which is in the paper, but it's our colleagues in Healthwatch England, Monitor, TDA, NHS England, NICE, and the professional regulators, including GMC and NMC. And in each of those cases, we're developing memoranda of understanding, and what I would say is that the memoranda of understanding have elements which are quite high level, and they're nice. They sort of explain what we're doing. They are underpinned by joint working protocols, and really importantly by the information sharing agreement, because that's one of the cornerstones of where we know we need to get better from Robert's work and elsewhere. So that is underway. The paper gives more detail on where each of those is. I just wanted to update the board as well on the work we're doing with the Royal Colleges, who colleagues and I have met a number of over the last week or two, and we've developed a shared MOU, Memorandum of Understanding, that we're working with the Royal College of Physicians on, and met with them last week with our perspectives on what that could look like. They have that. They are very positive about what we've done. They're making some changes, which they say they'll get back to us for tomorrow. And the aim there would be have something short that all medical Royal Colleges at a minimum can sign up to alongside us. So I think it's a powerful statement of the way we're going to be working together, alongside bespoke memorandum of understanding with individual Royal Colleges that will then reference the individual bits of work. And the reason why that's important is that there are a number of things that we can do for them, but just to focus on what they can do for us, they have a wealth of information and intelligence, including from their clinical audit and assurance programs, which is very helpful. Secondly, they are able to give a level of professional endorsement if they are confident in our approach, which then goes to the wider staff endorsement, which I think is important for the way of work we're doing. And the third is, starting with, or mainly in Mike's area, they will be able to support us in providing clinical experts for our in-depth intensive inspections. So we take this very seriously with the Royal College, which is why I wanted to bring it out alongside our arm's length body work.
Want to comment on that at all? You've been involved in some of the discussions with the Royal Colleges.
Yes, I mean, I suppose the good news from my point of view is I know most of the Royal Colleges quite well from my previous work, and they are absolutely critical to what we will be doing. I think they are really up for this too. That's been my impression. And I think one of the specific areas that we can work on with is in the accreditation programs that they are quite often doing, which may relate to a specific area of healthcare, like endoscopy or something like that, because if we can accredit those accreditation programs, we will then be able to take their work and build it into both our surveillance and our inspection, so we would then only need to inspect by exception. So I think that's where it'll be really valuable.
And also into our how we rate services. Sorry, Jennifer.
I thought this is great. It's a sort of dizzying array of MOUs. It's sort of struck me. I mean, I suppose I suppose the issue is, there's getting all the MOUs sorted and agreed and everything at national level, but there's the local physiology of how it's actually working. So to get some kind of flavour of that at a regular point here, I think would be really useful.
That's absolutely right. The only thing worse than reading a dizzying array is to write them. But I think I think you're absolutely right. The issue is this is an applied science, not a theoretical science. This really is about whether the CQC inspector speaks to the regional person in monitor about Hospital X, whether the inspector speaks to the local authority about care home Y, and the concerns about quality. I think why it's important that the information sharing protocols are probably the practical tools that sit underneath those MOUs, which are really about the how-to guides. And the one that I drew attention to in the Chief Exec's report, the one with the GMC, is really being championed by staff in both organisations as quite a practical tool that helps them exchange the relevant information at the right time. But I think, David, perhaps one of the things that might be helpful is at a future board meeting whether we might give a slot to an inspector and maybe one of their managers to come and speak to us about what they do. So as well as getting some stories from people that have used services, get some stories from our staff in about, and just ask them to talk about how they're applying that and how they're doing that. We know we need to have some kind of schedule of auditing this and checking out that this is something that's robust, and check that out with our colleagues, but that might be one way to do it as well.
Jennifer, on the local part, I think there's sort of 3 points of interaction. The MOUs can only really do the national stuff, and then as David said, there's the one-to-one interactions with a TDA colleague on the ground in North London, whatever it might be. But then the other part, as you know, in the architecture of the system with the quality surveillance groups, is just how we interact on those groups. Now, went up to see one in operation last week, and I was completely struck by two things. So first, it was how reliant they are already on our information, and they seek assurance from us, which is fine and good, but it's helpful for us to know that there's a lot of reliance, but particularly when it's the interface between health and care. There's an observation. But the second part is they are a new bodies set up from April this year, and what the one that I observed didn't have yet, and I suspect it's true in others, there wasn't a coherent risk framework. So there was a lot of discussion about what are you doing as a CCG. There are many CCGs around the room. So I think it won't be through MOUs, but it'll be a practical change on the ground as we roll out our local as well as our national surveillance. What do we worry about locally and regionally? By sharing that with the quality surveillance groups, I think we can provide a framework for the system and some alignment on what we should collectively be worrying about, which begins to answer the are we going in the same direction and how do we avoid missing stuff? So I think that's the third leg of this.
So at the Select Committee, David, we were asked about documents retention by one of the MPs. We said we'd do some further work on that. This is that work. So what this work will do, it's an audit which allows us to work out whether our policy is consistent with the international standards of document retention, and then we'll audit against our current standard whether we're keeping our records for the length of time that we should. The issue was how long do we keep emails was in the Grant Thornton report. That was a line of questioning at the inquiry. Well, we keep emails for a year. We keep our records for 7 years. So the question is our behaviour consistent with that policy? And actually the only way to check it is to do an audit. So this is what this is. I'm asking you to agree this audit. The terms of reference are there. The audit will be completed over the summer. So by the time you and I are back in front of the Select Committee for the accountability meeting in October, we should have an answer about how compliant we are with our own policy and whether that policy is a good one and it should be better than it is. So I'm asking you to, in effect, note that. That's executive action I'm taking, but I think it needs to be reported here.
Okay, everyone? Yep.
Yeah. And then the second one is the contract award. My delegations are whatever this figure, I can't remember. This is above that figure that I can't remember. It is for 1.4 million, and it's to extend the CRM, which is our client database, in effect, system within the organisation, to extend it for a further 2 years. This effectively keeps us with the same provider that was recruited by the Healthcare Commission going back prior to CQC's creation, and I'm asking for your agreement on this today so we can make the necessary arrangements to award the contract from the autumn of this year. Finance colleagues have recommended this to me, and I recommend it to you for agreement.
Okay. Ian?
I'm sorry to prolong things, but I do have one question, which is, I'm sure there are good reasons for it, but I was intrigued that we are embarking on a series of relatively short-term service contracts of 2 years, extended by a further year, another 2-year contract. Now that does a number of things. It pushes up our procurement costs because we have to have a significant retendering process every 2 years. It also makes it less likely that we will gain the advantage of the capital investment by the contractor in the hardware that they're investing in, because they will need to amortize that over 2 years rather than over 3 or 4 years, and therefore we're paying for that extra cost. Now there may be other valid reasons for doing a 2-year rather than a 3 or 4 year contract, to do with flexibility and to do with our changing requirements and not getting locked into a structure which we want to change through a variation order at considerable cost a little bit further down the line. All I'm really seeking is an assurance that those choices were properly considered and the best conclusion for the Commission emerged from that, rather than it not being considered or it just being chosen because last time it was 2 years or whatever. And you may not be able to answer that question now, but I'm not seeking to hold it up. But I do think questions did raise in my mind about why it was such a short contract.
I can't answer that. It's a straight answer to John's question, but hopefully in the next few days we'll announce the Director of Corporate Services. I think we need to be aware of investing heroic ambition on all these people that we're bringing in. But this is an area that needs looking at, I think, John, in a pretty cold way, and I think getting somebody in new to look at this will be incredibly helpful. And I think the person that I think we'll award the job to, I think we'll be able to bring that objectivity to exactly this issue. My take is I think we're slightly cautious of committing to big IT programmes, and I think that's what's reflective in this, rather than there's a higher form of strategy about it. I think this issue about how we support a predominantly home-based workforce is really the question I want to get the new Director of Corporate Services to begin to answer. And there'll be an HR, a system support dimension to those, not just looking at the kind of hardware stuff. And I want us to take a broader look at that. I think the previous audit plays to this as well, because it's how do we warehouse data, how long do we keep it, where is it kept, how do we get access to it. I want us to look at an individual case, and we're going to have to go and get Iron Mountain records out from a store somewhere in the north. This is not the way to be running a 21st century organisation, quite frankly.
But David, could you just put the question to the team why we went for a 2-year contract, not for a longer one? Just put, as long as they have considered the question and they've got an answer to it. But if you could do that.
David, do you want me to answer that now? Is that we did go through a process of saying the current software and hardware model underpins our current regulatory model and approach to registration and compliance. We know we're embarked on a major transformation programme of reviewing our regulatory model. It would be an ill investment to make a long-term commitment to a major IT system when actually we're at the beginning of that change programme.
That's fine. Camilla.
Maybe I'll just ask Hilary. I mean, so this is a fee for hosting a database that has already been built. £500,000 a year to continue to host a database. Is that right? Or are they doing anything else? What kind of
providing some support as well. So if we need adaptations to the database so we can retrieve things, there'll be a number of questions that have been. So that performance report that we've had, one of the reasons it's iterated so many times is each time there's a different question asked about how to access it. Somebody needs to commission a piece of work. So there's been a whole sequence of releases around CRM where we've had to design Hilary's point. So the best way to do this, Camilla, is my understanding we needed to redesign some of this when we took on the responsibility for registering GPs. So how we did that, and that was largely on a digital platform. The people that did the amendment to the database was CRM, and we buy that service. So we buy a design and build and operate service off them, in effect, where our role becomes the intelligent client rather than we do the amendments.
But they're charging us a fee every time we want to slightly change the way we use it. Is that what you're saying? So I mean, and presumably we've compared this cost to other hosting of other databases, haven't we? And we're satisfied that it's reasonable, are we?
I think we're satisfied it's reasonable in the circumstances.
Right. Okay. Well, that's.
So, but I'm not sure that matters very much. Are you? Oh, Healthwatch. Anna.
Thanks very much. It's a long report. I only really want to say one thing, and then I want to show you one thing. The one thing I want to say is that one of the things that I think we've become increasingly clear about as an organisation is that we always need to start with consumers, people. It would be a travesty if we have all bits of the system didn't do that. That's what we're set up to do. So 2 bits of work that we're doing at the moment. One around complaints, and the current phase of that work is very focused on engaging with people's experience through local Healthwatch. So this is a way for us to kind of really test quite how this network can work together, deliver some real value added by sort of putting stories together from across the country. It'll be the first time we've done it. We've done some webinars with Local Healthwatch already, which is kind of yielding some really rich information, both about what the issues are in complaints and also what the issues are with the processes around complaints. So both dimensions. The annual report, which will be published on October the 9th, will be very much focused around this notion that actually we need to develop much more of a sense of rights, expectations around health and social care. And in order to do that, we are doing, again, some research, well, this time some research with consumers and users of care, health and social care. So we had a very big deliberative event a couple of weeks ago, which was absolutely fascinating, where we asked people what they thought were their kind of expectations, what things they ought to be able to get from health and social care, what they thought their rights were. They started on a journey of feeling that actually they probably didn't have any. I think they're probably kind of right. But they ended up in a place where they thought, actually, yes, we should be getting this, and we should be getting that, and this is a sort of slightly different place. That work will form the basis, the kind of the structure for our annual report to Parliament, and we will want to collect and collate a sense of how well the system is doing against those core expectations. So that again is starting with consumers and users of services. We commissioned for our annual conference a short video of people talking about what they wanted from Healthwatch and Local Healthwatch, and I just wanted to show you that, if you don't mind. It's only a couple of minutes, but part of the reason I want to show you is A, because we'll give you a sense of what people are expecting, what the general public are expecting from Healthwatch as a network, but B, actually, I want to crave some support from you, because having got this DVD, which we're making available to Local Healthwatch, we're really keen to get it out there as widely as possible. So if you have thoughts about ways in which it could be more widely distributed, both actually to system players who don't always know certainly about Local Healthwatch. I mean, some CCGs really not as au fait as they probably should be, for example, about Local Healthwatch, but also to consumers and users of health and social care. So it's a kind of resource which we'd like to make available to people to talk about what Healthwatch is and what people could expect. And I think the team are going to just play it for us.
When it comes to health and social care, we all want the best services we can get.
Whether we only need help now and again.
Whether the quality of our lives is affected.
Whether it's a matter of life and death.
Now, through Healthwatch, we can make a real difference to the way these services are run.
Healthwatch gives us a voice, even for those who sometimes may feel left out.
They'll listen to our views about how we're treated and how we're cared for.
And they've got the clout to do something about it. They'll help us shape our local services.
And armed with our evidence, experience and stories.
They'll ensure our voices are heard and responded to on a national level.
It's good for us to provide services too.
As Healthwatch can tell us what really matters to people who use our services.
And at a time where there are so many big changes to the NHS and social care,
it's a comfort to know Healthwatch are there to shape those services.
To see what's working and what's not.
And to champion our needs too.
So we're treated fairly.
With equal access to the help we need.
Healthwatch is independent.
Because they're not part of the service we provide.
That gives us the trust to be honest with them.
This is our opportunity to be heard.
And for us all to learn.
I can make a difference.
I can make a difference.
We can make a difference!
So the only thing I'd add is that I mean clearly that's a big ambition for Healthwatch, and we're not the people who can do much of what they want us to do. But this was in people's own words, and what they see Healthwatch as is a vehicle for helping them to achieve some of that. Now, the way that we will do that, of course, is by challenging and advising other bits of the system nationally and locally to do what they would like to see done. But it is what people want to feel they've got in Healthwatch nationally and locally, and I think a better way to talk about what we might be able to do if people speak, use the channel of Healthwatch to speak to the system, than us telling it ourselves. So I'm very happy to take any questions on the rest of the report.
Thanks very much, Anna. I like that, actually. Really good. Any, okay?
A couple of points. Could I mean, we've got obviously Healthwatch England and we've got local Healthwatch. And yonks ago, before it was Healthwatch, there was a sort of debate about individual and collective voice. You know, are we championing, or is Healthwatch championing collectively at a sort of local level, or is it actually helping individuals assert their rights and make a complaint? Because that, I know originally, was sort of going to be the focus, that it would be about helping individuals who had a problem and helping them sort of raise concerns and make a complaint. So I'm just wondering, has that sort of changed? Is it more about sort of involving local communities and them influencing, you know, local services? And it's not about helping individuals. That's definitely not what it is now. Okay. And the other thing is just to ask about again about the setup stages of local Healthwatch, because I can see you've got quite a good working relationship with the local government association, but it's still quite a significant concern is the funding actually of the local Healthwatches. Some seem okay, but others were, you know, seem woefully underfunded. And I know we can't influence it directly, but it'll be helpful to kind of know, one, where we are in the setup of local Healthwatch, but also what role that the funding is going to play actually across the country. Yeah.
One of the ways in which we're talking about local Healthwatch having three particular functions, if you like, which I described in my contribution at the national conference, and they are to take what they learn from being engaged with their communities and coming to them, and make sure something happens. And that could be at an individual level, but it could also be at a collective level. It's not specified. It is to take something which it is clear is a big issue in their community, which might come as a result of looking at, for instance, the data that comes from Public Health England, kind of cut down to kind of local perspective to see where the issues are in their community. So it might be a kind of top-down identification of an issue which in local terms needs addressing, regardless of whether people are coming and saying they need it to be addressed. So there's a kind of a proactive and a reactive function, but both really are mostly, as you describe, about trying to make the system better for everyone, albeit occasionally focused on an individual experience. And there's a third one, which is much more focused on individuals, which is the signposting function, which is much more about empowerment. It's about giving people the tools and techniques and the information they need, and the education potentially they need in order to be able to use that information so that they can find their way around the system. So there are those three things very clearly. Now there's a fourth element which is commissioned at local level, which in some cases is, as I'm sure you know, Kate, commissioned to local Healthwatch also, but in many other cases it's not, and that's what was the old complaints advocacy function, which is the bit of the system that delivers support to individuals in order to pursue their cases. So we've got a very mixed economy in respect of what's of that position. And I think one of the things that's coming out of our complaints work is the sense that actually the situation is a bit worse than it used to be, where we had a small number of providers for advocacy services up and down the country. So there may be something, so watch this space, I think there may be something that needs to happen in respect of that. So the picture in relation to individuals is a bit bitty. Is the honest answer to your question. but to move to where we might get to, so one of the things that we're doing at the moment is creating literally a series of maps of local Healthwatch as we're finding out more about them. And it's true to say that some are still very much in setup, some don't have chairs or boards or don't have directors, or what. So whereas others are streets ahead doing great stuff. So the mapping will include such things as which of them do have advocacy functions alongside their local Healthwatch. So we'll get that picture very shortly. That's a question we're asking at the moment. It will also be a mapping of funding. So we will know what the budgets of each local Healthwatch is. Just before I talk about how we might use that, the picture actually is that there are many Healthwatch that have got considerably more money than was originally identified as the kind of target figure. So lots of local authorities have found other pockets of money, particularly in this set-up period, that they and other activities which they want local Healthwatch to do. So it's by no means all bad, but we know there are one or two examples where the budgets were extremely low. So one of the projects we've got with the LGA is working with local Healthwatch to define, if you like, what good looks like, what a sort of standard of good practice might look like in relation to local Healthwatch. And I think if we can, in due course, and certainly by the end of this financial year, begin to map that against the funding, we'll begin to get a picture of whether there is, if you like, a level of funding below which you just cannot do it. Which I think will tell a story which we in the LGA will want to discuss and think about how we might raise through our various mechanisms. But I mean, it wouldn't be to say this is the budget you must have.
Any other question, Paul?
Yes, you mentioned about the deliberative event and this being the basis of some of your annual report to Parliament. I think if I heard you right, I mean, what's quite important about that is the beginning of the event, people didn't think they had any rights. At the end of the event, they did. Parliament has the tendency to think people, because the legislation's been passed, people automatically know their rights. It's a myth that goes around sort of for several hundred years that Parliament does things, whereas actually there needs to be activity. And so I seriously think in the annual report, demonstrating that the only way people know their rights is to have something like a deliberative event is an important intervention in actually realising these rights rather than simply assuming they're there. And I think Parliament does need education around that. Knowing how MPs do generally want to increase people's rights and how they experience actually what that deliberative event is, how it might work in a locality, how that might work in a region, I think would be quite useful for Parliament to understand.
Right. Yes. Yeah.
Are the consumer rights you're envisaging, are they going to be the same as the NHS Constitution, or are they different?
So we started with what consumers thought of as their rights. We during the course of the session introduced a set of, there are 8 consumer rights which are widely agreed and accepted at international at the level of the UN. They're widely used by consumer organisations. They're pretty unexceptional. They're things like the right to choice, the right to information, the right to redress, the right to voice, those kinds of things. So we introduced those and said, well, how does this match against the work that you've done? And not surprisingly, because they're not rocket science, there's a very good match. We're also having a very interesting conversation with a group of people looking at the way in which the NHS Constitution might be used to deliver more traction. Of course, our work is across health and social care. The NHS Constitution is only NHS, but we did with that team a mapping of the NHS Constitution against the existing 8 consumer rights. And what do you know? There's quite a good fit. There's some gaps, some interesting gaps which are worth looking at, and the NHS Constitution is a level of kind of micro detail and specificity in some of these areas, which is not really helpful because you can't remember the detail of that. But if actually the headline is the right to information, you can remember that. That's something that is more empowering. So we're talking about how Healthwatch can become what's being called an interpreter for the NHS constitution, perhaps building in this broader overarching concept of consumer rights, but recrafted slightly as a result of this research.
That's really interesting, because I've just become very conscious lately. You know, people are very confused. They still think there's a patient's charter. I don't even know whether that still exists. The NHS constitution, I think, is really excellent, but it doesn't have much traction. It's not. People are not very aware of. So if we could end up with one thing that people could, that would be.
That's the plan.
Yeah.
Thank you very much, Anna. Thank you. John, it's for information, I think.
It's information. I'm happy to answer any questions either in the meeting or outside.
Thank you. The board forward plan, nothing on that, Claire, I think. Right, any other business? Sorry, yes, the gentleman on the back.
David described me as his proofreader for his paper, really, and coming here as Healthwatch. Actually, I've come here today from a small community group called Kingfisher in Gloucester, really, and I asked permission if I could come, really, because I know everyone else is busy round the table and whatever, really, but today they're exceptionally busy with 200 children. There's summer activity week. Many of the little children are known or referred from social services, and for a great many, that will be their holiday for the week, really. So, purposely asked permission to come today, really. I really liked Robert's point about getting out there and talking with people, whatever, really. I think it's a very obvious thing to do. There's the bits about how we do that as well, and the timing of that, and again making sure that when we do that, you know, we make sure it's effective, both for the person we're speaking with and also the organisation, really. You described Robert's report as seminal, really, and I just wrote down immense, really. I've had the pleasure of hearing Robert speak about the report on a number of occasions at the NICE conference and whatever, really, and what I really like about it is it's an absolute immense report, and it's delivered by an immense person as well, with that passion and commitment behind the words. For me, what I heard today was a lot of discussion around CQC in terms of that very corporate level, but what I was really pleased with was the interjections around actually what does it really mean at a local level. What does it mean when I speak to someone in Gloucester or Gloucestershire or other people here from other health watches, really? What do they tell me about the trust and integrity that they actually feel for the Care Quality Commission? So I think overall for me it's great nationally, but actually really my focus is what does it actually mean and what's its impact locally, really. I wanted to join a few of those things up and whatever, if I may, and whatever, really. One of the things that I was told to do today, whatever, really, by people at Kingfisher, really, was to pass a message to Kay, really. And that bit about getting out and seeing people, and Kay's, you know, we've been very privileged to have Kay to come down and see 200 people with learning disability at their disco evening at a time of their food. And the sort of things that kept fed back to me was how easy Kay fitted in, really, how easy Kay felt welcomed and welcomed, really. So one of the things I asked, really, with the permission to come, is what would you like me to say, really? And what they clearly told me to say, and Jan, who leads a lot of this work at Kingfisher, said, is you give Kay our love, our best wishes, and our thanks, really. So I've done that. The other thing I picked up from Kay as well, really, and I picked up many, many times from just listening at the board, really, was the word culture. I heard that a number of times, and we know that it's not easy to change, but actually we know what we know as well, really. And I think the words that Kay said about the fact that she didn't feel that was going to change, or was changing, it was going to change, she wouldn't be there, really. I jointly co-chair the Care Quality Commission's Qualities Group with Kay. I'm very privileged to do so. And I'd actually echo those words as well. If I didn't feel that actually, you know, we've set things in place now, and yes, we'll have to test them, and yes, they'll be challenging, but we have to achieve them. And I certainly would be there with that in that role, or any role. So thank you for listening for me. I've done my job. When I feed back to the people, they will say, "What did you say, Bren?" So we've got a video to prove it. But thanks. And also what I like about the culture really, in terms of you open this, you open up for people to come and literally have a say. And I think that they are very, very powerful messages. So it's not just words that we say, you know, we have a public meeting or whatever. You invite the public to have a say. And that, for me, is an exceptionally powerful message, really. Thank you.
Bren, well, Bren, you're very welcome to come anytime you want, and thank you very much for the contribution you made. And feel free next time to chip in, you know, during the meeting if you wish to do so. And very much noted the comments you made about Kay as well. So, and we're delighted that Kay is with us for the next 3 years anyway, Kay. So that's terrific as well. So thank you very much for coming. Just before I close, there's one thing I should have just said, and that John Lappin, not all of you will know John Lappin, but he's retired from the board last time. He just wanted me to make it clear he's retiring. He wasn't sort of going as a result of the Grant Thornton Award or anything like that. That's it, I think. We're going to have a quick lunch now and then reconvene 2 o'clock. Hilary, is that all right for you to do it at 2 o'clock? Are you able to do it at 2 o'clock? I think we'd rather get on with it, I think, probably, please. Good. Thanks very much. And Robert, I should also thank you very much, and thank you for bearing with us for the rest of the meeting as well. So thank you very much. Thank you.